It's 7,000 euros in acute treatment per patient in Germany, and 1,300 euros in Spain. So obviously the Spanish guys, they are very much interested in this question. And then there's another older study, the cost of lumbar back pain between 2001 and 2007. There's a literature review, and annual direct cost is about $2,900 US dollars per patient, and indirect cost about $16,600. Epidemiology, low back pain, third world. So this is a question: do we differentiate between high income and middle income and low income countries? Is there a difference? 15 results in the last 10 years, mainly chronic and very, very specific. Very few recent studies, most on discogenic pain. So there's one old studies. It's about 30,317 patients, 16 publications. And this study included only acute back pain. And you see very nicely here the difference between the high income countries and the low income countries. You see here. Let's see if it works. Yeah. Oh, very slow. Okay. So all the high income countries, they have a much higher prevalence of low back pain than the low income countries on the left side. Very interesting study, but 25 years old. So this is the second statement. What are the costs of back pain treatment? And is there a difference in high and low income countries? Well, there's a significant direct and indirect cost factor in all studies found. When we look at the last 10 years, basically we only have this Spanish study. And there's a significant difference of prevalence and incidence of acute back pain between high and medium and low income countries, but we have to refer to these rather old data. So now risk factors for acute back pain. 81 results, mainly old and addressing acute, becoming chronic back pain. This is a problem. This is a frequent question asked in these papers is, when does acute become chronic? Which is not that much in the focus for our consensus. And well, this is some of the ideas what they wrote. I will skip this. You see here, which is just 10 years old, the paper. It's database research, and they did a lot of M-based, Medline, and so on. They reviewed at the end 7 studies. There was no significant in the overall activity level of adults and adolescents with chronic lumbar back pain. It's unfortunately only addressing chronic. In the older adults with chronic lumbar back pain, there was an association with the less activity. Another one, this is, oh, I missed the year. No, I think it's 2013. Cross-sectional based study, 102 subjects. Obesity was proven to be a risk factor for lumbar back pain, but not for becoming chronic. Just to have lumbar back pain, obesity seems to be a risk factor. There's an association of body mass index and socio-demographic variables. And at the end, they discussed in this paper if obesity is the real risk factor or it's only the poor social status. It's because obesity and poor and rather critical social democratic status is associated. So at the end, probably you're obese and you're poorly educated, and it's difficult to say if obesity really is a risk factor. Probably it's not. Oops. Yeah, so there's one more. This is also just acceptable, 10 years old. Evaluation of coffee consume, sitting behavior, and cigarette smoking at 609 subjects. Well, if you are a sedentary lifestyle, increase the risk of recurring low back pain 3.5-fold. Excessive coffee consumption, significant increased risk of low back pain recurrence, and smoking increases the likelihood of recurrence and becoming chronic. but it's not of having an acute back pain or not. And then another paper, systematic review of prognostic factors for return to work in workers with subacute and chronic. So I included it, subacute. 64 subjects, and regular movement in the sitting and change of the position showed a trend for reduction of back pain, but it was not a big influence. So when you tell the patient, maybe directly after surgery might be one, but not if he just works in a sitting behavior and he changed the position, it doesn't make big difference. There was a trend, it was not significant. So the last statement, what are risk factors for acute back pain? In contrast to chronic and recurrent back pain, risk factors for acute back pain are not well defined. So obesity is a risk factor for recurrence. Smoking is a risk factor for recurrence. What else? We had a coffee consume, sedentary life, but for acute back pain, to have acute back pain, it's not well defined. So prevention, last part of my talk. 926 results, mainly old. Frequently, they address chronic back pain. NAS guideline is as well checked. The NAS guidelines include papers until 2016. I did not mention this. Was published 2 years ago, but only included the papers until, I think, 2016 or 17. Prevention of low back pain, it's February 2016. Literature review, 23 published reports, 21 different randomized clinical trials, about 31,000 individual participants. Risk reduction by exercise, moderate effect. And then if you combine exercise with information and educational level, so the better you're educated, the better is the effect of exercise. So obviously there's a strong correlation and strong effect. But basically this is the same, chapter 2 in the guidelines for prevention of back pain, the physical exercise and information and educational status. So this is a 12 years before this was already in the guidelines. And then effectiveness of 4 interventions for the prevention of low back pain. It's an old paper, JAMA 1994, 64 articles. There's limited evidence to recommend anything and insufficient evidence to recommend exercise and insufficient evidence to recommend other prevention strategies. And another rather old one, 12 years old, 13 articles reporting on 9 studies with 9 interventions, a total of 407 participants post-treatment and 1,100 participants valid exercise as a treatment modality, and moderate quality evidence that post-treatment exercise were more effective than no intervention. So it's that when you do an intervention and the patient is immediately pain-free or pain-reduced, they can better exercise, and this was the idea of the study, that this helps the patient to recover. There's moderate quality, but it's an old study. So statement 6, prevention of acute low back pain. Exercise and educational status reduce the likelihood of acute low back pain. So now I come to the questions and answers. I'm almost late. We have 2 minutes. You have to prepare now yourself. Are you all ready with the questions and you put your answers? What is the prevalence of lumbar back pain and what is the incidence of lumbar back pain? Well, I found only one recent study with significant impact. In this recent study, there was a prevalence of 38% and lifetime prevalence of 40%. And well, you can vote now if you agree with the statement, or we should rather not agree with this statement and make it more subtle, because there's very, very few evidence on this when you look at the acute lumbar back pain. So now you vote. Yeah.
Discuss now.
Yeah.
And then we can add on the beginning of this statement, acute back pain prevalence per year is about 38%. Lifetime prevalence is 40%. So that it won't change in the statement.
So what do you want? Tell me.
In acute back pain, low back pain, prevalence of
Per year is 38%. Like this?
yes. So that prevalence in acute back pain is 38%. Like that prevalence. We start with prevalence.
Why is that? Okay. Then I need 1 year prevalence, huh?
Yeah.
Okay, we can do like this, right? I just save it. Wait. So what's today? 14. So then we should do this in all the presentations. I think then it's best. Then we have it like this. Okay. 1 year prevalence in acute low back pain is 38%. Lifetime prevalence. What do you want? What do you edit, Simon?
Instead of comma, just say and. So that's it.
Okay, and it's 40%. But this is only one study, and we excluded the old study, which is, I think, much better. Are you sure that we shouldn't make this statement? I would not agree. Because it's only one study. Exactly. This is what we have to discuss at the end. I said about methodology. If we include older papers, the prevalence goes up to 40% in all the studies, but it's much more variable. So they start like 10% or 7%. But most of the studies, I really like this North Carolina study. They just looked at the phone book and they called somebody. And these results are very different. Look at this, right in the beginning. Was one of the very first. Here, that's only 11%. They all have a bias, you know. So if we make 38, I think this statement is not a statement. I think our statement should be, we have actually no real data. It's up to 30%. I would not be that clear. Okay. Okay, good. And then we can say, yes, this statement is true. Okay, let's do that. I like that. Where are we? This, right? Okay. Limited recent data. We don't have to use full sentence. Okay, anyway, although there is limited recent data, 1 year prevalence in acute low back pain is reported to be up to. Is that okay? The problem is if I include the one old one, I have to include all other old ones, and there is some with only 7% or something. So up to, then we say is to be 11% up to 38%, and lifetime prevalence up to 40%. How is that? Up 11 to like this? Good? Does faculty agree with this? If we proceed like this, we will not be done tonight, guys. It's okay. It doesn't change the meaning if we make a dot or a comma or whatever. Is that okay? Okay, let's go to the second one. Yeah, the faculty is, the faculty has to vote now. And the others also have to vote. When are you going to display the results? Where's Imad? Imad, you're going to Imad? Yeah, we go run late otherwise. So what are the costs of back pain treatment? Is there is there a difference? Not R. A difference in high and low income countries? There's a significant direct and indirect cost factor in all studies found. Well, personally, we can cite this Spanish study, but I think it's not representative. It's so high, these costs. This is the only recent study which was really well designed because they used all healthcare data all over Spain. But it's, 8.9 billion euros. It's too high, I think. And 74.5% indirect costs. So in Spain, if you have back pain, you never go to work back. This is the meaning, right? Yeah, let's go to Spain. If you have back pain, you made it. This is the thing you made your life. So yeah. Okay. For back pain, huh? For back pain treatment. Exact cost of or for acute low back pain treatment is unknown. Good. And then there's a significant difference in prevalence and incidence of acute back pain found, which being much more frequent in high income countries.
Yes, so maybe you can just have this at one statement, both the statements at one statement. Let's say statement 2.
What?
We have one statement, we have just voted for one. All of this as statement.
Yeah, this is 2. Okay, so this is statement 1. And do it like this, and this is statement 2. Okay, so no new sentence, no new paragraph like this.
Yes. The last question is significant difference of prevalence and incidence. Back pain is one, and much more frequent like income factors.
And what?
And it is much more frequent in high income countries.
Okay.
It is.
Like this?
Yeah.
Okay, it's only acute. The chronic actually is not a big difference. Okay, good. So now you vote. Does it work, Imad? You're like a little bit scared. Is everything okay? Yeah, at the end. At the end, he will show the votes, don't you?
Yeah.
Okay. We move along. The faculty vote? Good. So then, 2 more. Statement 3. What are risk factors for acute back pain? In contrast to chronic and recurrent back pain, risk factors for acute back pain are not well defined. So we have obesity, smoking, coffee consumption, sedentary life, but it's all for recurrent or low or chronic. It's nothing for acute.
For instance, there is no good pain
No, because the problem is they have back pain, but at the end they're all chronic. You know, the thing is that they're risk factors, but those are for recurrent and chronic low back pain. They are not for acute back pain, which goes away and does not become chronic.
Yeah. Is there any paper telling that there is a relation with acute back pain and any trauma?
I did not specific trauma. I did not look up because I thought we focus on degenerative.
Probably we have to include there a specific back pain because 90% of back pain is not spine back pain. That's why it's no risk factor.
There is actually a problem that it's kind of dismissed because
Yeah, they have no papers on it.
nobody is treating back pain unless it's a specific treatment line.
Yeah, yeah.
There is no papers.
I would leave it like this.
Yeah.
So you vote now, statement 3. Oh, we are so late. Ay. Someone, you have to catch up. Faculty vote is done. Last one. Statement 4, prevention. Exercise and educational status reduce the likelihood of acute low back pain or to become chronic. Okay, that's it.
This educational status is the learning how to prevent.
No, this is information. Educational status is if you're academic, not income. Income does not influence it. If you're very rich and you are self-made millionaire, it doesn't mean anything. But if you have an academic career, it's much more the exercise and will have a much better effect on your results. It's much less likely to have recurrent back pain. Probably you change it. You're either earlier and more willing to change your lifestyle. Maybe like this. Yeah, this is another idea. What are the reasons for this is not known. But those who have a higher educational level do much better in prevention of recurrence.
Let's say exercise and for people with higher education status. So that's very clear. Otherwise, education status.
One more thing, I think patients who have a carry the label as patients with back pain, they're limiting the that's why we have to put it in the statement because it's to follow the.
Now this is prevention. This is patients who had a period of acute and are over this period, and then they're educated and change their activity and change their daily behavior, and then the likelihood of recurrence is less. It's not that they cannot move. Not good. Paper is not good. But then that's higher. Okay, like this. Okay, you vote now. And that's it. This is, I thank Dr. Kanchok who did some of the literature research for me, one of our residents. And this is our endoscopy week in September. You're highly invited to come. Thank you. You use my laptop or yours? You can use my laptop if you want to, but then I cannot do anything. Yeah. So what are the results of the voting? We don't see it now?
Once they enter in the then all of them. Until they enter it.
Again, thank you. I'm just going to move on. I think we are running very late. Yes. That's theirs. Yeah. Okay, so my topic today is acute back pain etiology and clinical diagnosis. So when we did a literature search with Medline and PubMed, we had 2,245 hits. Recent papers in the last 10 years were 1,400. Relevant articles that depending on prospective studies, randomized controlled trials, and excluding all those articles which were different language. Along with that, there were some case series and case reports. If you did that, then articles that were included in the study were 97 eventually. Etiology and source of back pain, obviously intervertebral disc, facet joints, muscle, ligaments, nerve sheaths. We know all are pain generators. We know this, that it's, these SI joints, intervertebral disc, facet joints, etc., can cause problems up to 40, 45, and 13% of the cases respectively. Discogenic back pain, I'm not going to go into the whole cycle of this, how it's formed and what it does. Okay, cigarette smoking, increased degeneration, increased risk of disc herniation. Okay. So disc disruption causing back pain, provocative discography is the only test. Painful flexion in discogenic pain, we get this. Facet joints is the cause of pain. Facet joints are supplied by medial branch of dorsal rami. Not going to go into details of that. The largest scale study to advocate a positive association between facet joint arthritis and back pain was in 2013, and they showed the presence and extent of severe facet joint arthritis was associated with back pain in community-based older adults, independent of socio-demographic health factors and disc height narrowing. So none of them were important in these people. Facet joint accounts for 30% of all causes of back pain, and diagnostic criteria in facet joint injection with steroids, and we see the symptomatic improvement, then we know it's because of facet joint. Features of pain is that pain usually, the patient complains of pain with somatic referral to leg terminating above the knee, usually in front of the thigh or going into the groin. So that's a typical pain of facet joint that we see. There is no radicular pattern. Back pain tends to be off-center, and the pain intensity is worse than the leg pain. Pain increases with hyperextension, rotation, lateral bending, and walking uphill. So all these factors, you know that it's a facet joint pain. The characteristics are typical. It gets worse when waking up from bed or trying to stand up after prolonged sitting. Patients often complain of back stiffness, which is typically more evident in the morning, and especially when you have some kind of arthritis associated with it. So there were 7 features with facet joint pain: older age, previous episode of low back pain, normal gait, maximal pain with lumbar extension, but a failure to aggravate pain with a Valsalva maneuver, and lack of leg pain or muscle spasm in the leg. SI joint pain, inciting causes of SI joint pain may mimic, ranging from repetitive low impact activities to higher energy trauma like motor vehicle accidents. Variability exists in the clinical presentation of SI joint, from localized pain or tenderness in the SI joint to radiating pain into the groin or into the leg, just to the knee generally. There is no pathognomic clinical history according to this study. Physical examination findings or imaging study exists that none of them are available to a clinician making a reliable diagnosis. So it's very difficult to diagnose SI joint, and majority of the time it's clinical, and many a times, yes, MRI, CT can give you some evidence. Although provocative physical examination have not received reliable consensus, if there are 3 or more provocative tests are positive, we pursuing a diagnosis of SI joint may be acceptable. SI joint causing pain is innervation is still not well known, but has been reported. Not going to go into that. Ligamentous, capsular, etc. It is generally underdiagnosed. We all know that. The patient complained of postural lower back pain that worsens in sitting position and postural changes. So SI joint test, Faber, compression, distraction, thigh tests, and Ganneslin test. Soft tissue sources of back pain. Paraspinal muscle pathophysiology associated with low back pain and spine degenerative disorders. So common muscular sources, multifidus, erector spinae, inflammation and fibrotic changes in the muscle leading to chronic back pain. At a cellular level, there could be increased connective activity, fatty infiltration, and atrophy contributing to muscular source of back pain. What about lumbocervical fascia? Yes, it can display a dense nociceptive efference, and these innervation can cause problems when you have got lumbar flexion and specifically a source of pain in the lower area. Then there are myofascial pain. Myofascial pain is characterized by presence of trigger points that are located in the fascia, tendon, or muscles, which when triggered results in symptomatic pain response. Trigger point is hyperirritable spot in skeletal muscle associated with hypersensitive palpable nodes in taut bands. So you have bands, and if you feel them, then you feel nodes in them. So in spite of lack of well-designed study, the best available evidence supports that trigger points develop after muscle overuse. So a key factor here is local ischemia, acidic pH, etc. So etiology of myofascial trigger pain, I'm not going to go into details of that. Physical examination may reveal localized tender spots in a taut band, again, with patients' pain recognition, referred pain on palpation, and decreased range of movement. When inserting a needle or snapping a trigger point, a twitch response can be provoked, and it can be seen when you're doing these patients. What about effect of yoga and myofascial pain? This study from 2014. So psychological stress, muscle tension, physical factors such as poor posture can cause a latent trigger point to become active, causing the pain. So these are the theories behind it. Lower back pain and neck pain, is it possible to identify the painful site by palpation only? So diagnostic criteria proposed by Simmons in 1999, and then go on, these guys went on to work on this. So they identified, again, taut bands eliciting pain on palpation and patient feedback as being the most clinical relevant in determining the presence of myofascial pain. Diagnosis and differentiate. Provocative maneuvers, so Faber-Patrick test, reliable in 85 to 95% of majority of the studies. And we know how to do this. Gapping or distraction test, supine patient, not going to go into that, you guys all know about its reliability up to 88 to 94%, to basically showing you the exact way of doing this. Compression test, so side position, flex hip to 45 degrees, reliability of 74 to 91%. And this is how exactly we do it. Turn patient on the side and compress. Differentiating etiology. Lower back pain versus versus a facet pain. Facet pain is often described by a patient as a deep and aching sensation with unilateral or bilateral distribution. Occasionally radiates to one or both buttocks, groins, or thighs, but doesn't go beyond the knee. Factors that exacerbate, we've just talked about it, psychosocial stresses, lumbar extension, physical activity. So prolonged sitting or standing, and then you move, then you have this pain. Physical examination will often show tenderness on extension, lateral bending, and paraspinal palpation, and you feel it exactly where the facet is. A discogenic pain, as we say, is going to be discussed later. SI joint diagnosis, we have talked about it, 2 or 3 provocative maneuvers. Soft tissue myofascial pain, palpation over the trigger spot, range of motion is reduced. Pain that is provoked by forward flexion, it suggests a discogenic or vertebral body related pathology, because flexion of the spine causes axial loading, and that's why we have that. Patrick's test evaluates hip and sacroiliac pathology, both of which are associated with lower back pain. Pain in the groin area suggests hip pathology, while pain in the back suggests SI joint pathology. So we know clinically how to diagnose these patients. Mechanical back pain, terms used for all acute low back pain without red flags and neurological deficits. It encompasses all forms of discogenic, myofascial, and facet pain. Not going to go into discogenic. Myofascial is when back pain is triggered by touching a tender spot. We've talked about it. The best recent study, which includes randomized controlled trials to address the etiology and clinical factors, were shown in that study. So let's see if we can go through these statements and see if we can improve them, or would they be reasonable for us. So statement 1, let me just escape this. Centralization of back pain. Oops, what happened here? So the only way it would work if I, Imad disappeared. Can somebody get Imad? Because I want to change if you have to change. Centralization of back pain with worsening on flexion, coughing, or Valsalva maneuver, and pain relief on recumbency suggestive of discogenic back pain. You're saying not to vote on this?
Can we morning stiffness?
Well, they can't see it over what you're doing. I want to see over there. Oh, भाई, last बिल्कुल नीचे, वापस नीचे. But I want to see what I'm doing. Put screen नजर आ रही है ना? Slide 1. Yeah, statement 145. नहीं तो ये वहाँ. अरे अभी तो देख रहे थे वो उनको तो नजर आ रही. We want to hide from you. Okay, yeah.
Can we add morning stiffness to that?
Yeah, sure. Maneuver, comma, morning stiffness. No, so it's comma, pain relief, comma. Pain relief on recumbency. Yeah, it's good. Read kar. And sorry.
I mean, that's discogenic is anatomical term. That's why discogenic is not right. Not only discogenic. All that pain is true for its state.
No, you're right. But at the same time, with stenosis, you may not have these symptoms of coughing or Valsalva maneuver making them worse. Generally, it's when you get up and walk about, then you have a problem with stenosis. It's also the same symptom, but not this. And morning stiffness. No, this is pain relief on recumbency and after that, one morning stiffness. So what Artem is saying is that this could be all that you would see with stenosis as well. Are suggestive. Mehmet, you want to vote on this? Okay, so let's just vote. Okay, if you disagree, you just put in disagree. Okay, statement 2. Back pain with unilateral or bilateral distribution that worsens on lumbar extension is suggestive of Pheasant joint pain. Okay. Okay, let's vote. All right, statement 3. Facet joint pain may radiate to buttock or thigh, but not below the knee, and is not exaggerated by Valsalva maneuver or coughing. So it's not neurogenic pain. Okay.
This can be added to the
Okay. Okay. Copy it in the statement 2. Just no, go. Yeah. Don't make second point. Just yeah. Thank you. So go to statement 4. Going to 4. So that's going to be 3 actually. Having 3 positive provocative tests for SI joint is suggestive of SI joint pain. Do we need to put the test here in bracket? Yeah. So we will put all the 6 tests here in bracket. So they're simple. Yeah. So just say we need to add that those tests here in the in bracket once you're done. So let's vote. Statement 3. Okay. So this is statement 4. Presence of taut band trigger points on back with hyperesthesia that reproduces pain on firm palpation is suggestive of myofascial pain. Okay. So statement 4 we vote. And that's it. Let's quickly move on. Next. It's okay. We can.
Just take the laptop, correct it now, and send it me now, because otherwise you will not remember this. Let's do it now. Next 5 minutes, you have to send it to me. Take the laptop. Be happy.
But I could change it. Go ahead, Carl.
You can.
Okay.
Yeah.
It's better that everybody brings their.
Presentation is.
There.
Yeah.
To one computer. Yes, it's here, my presentation. I just think that it's easier to change. But it's okay.
It's not your laptop?
Is it not? No, it's
You send it now. Send it now. Correct. Send it now. And then you have to be back on the next question. Let's continue.
yeah.
Is it working for you? Oh, why are you so late? You missed the most interesting part already. Okay, look at your here. Midline, send them after you're done. Do this first, and then you send them your notification. Okay. Professor Kusha from Moscow. Let's continue. Adam is going to talk about radiology diagnosis.
Thank you, Joachim.
Fast, and then at the end comes
Okay.
all your questions.
Okay.
Because we see that we need more time to discuss.
Yeah, I'll try to be very fast. My dear colleagues, I'm very happy and we're very proud and privileged to be in this consensus meeting, and thank you to invite me to be here. And my question is radiological diagnosis for acute back pain, and as a acute sharp back pain in Pakistan, everything's sharp, mountain, food, ideas. So I just want to remind you that appropriate imaging is very important for investigation of acute low back pain, and at the same time, the self-improvement of the acute back pain is finally coming very often. According to Institute Clinical Systems, oops, doesn't work. How to? Okay, I'll do it here. According to investigation of Institute of Clinical System, it's pointed this article here. The acute back pain, it's actually a pain syndrome which limited 4 weeks. It's very important because we have to state this information in the final statements. The same time, according to initial evaluation, the 90% of back pain, acute back pain, is not specific. So first of all, the doctors should subdivide, attempt to place the back pain on the 4 groups, like non-specific back pain, 90%, and the rest could be spinal stenosis, radiculopathy, or some serious underlying disease like malignance, fracture, and it's pointing at very different articles. I pointed here only article Low Back Pain by Cohen, which clearly subdivide the intensity and the percentage of non-specific back pain, which can become in low period, like 4 weeks only. So the first question, when to order a radiological investigation in case of acute back pain, and is it also was founded that's based only on the different guidelines. Our colleagues in States and United Kingdom, they reduced the amount of investigation on 36%. So 1/3 of all investigation wasn't need to the patient, and they just multiply all the guidelines in one protocol and start to subdivide the 4 main categories which provide low acute back pain: malignancy, fracture, Cauda-Equina syndrome, and infections. So finally, the system on red flags is very popular and quite fruitful, because we having the certain red flag symptoms like an ischioenergetic trauma, which can provide the fracture for osteoporotic patient, possible tumor infection, which resulted for the young patient or old patient, or history of cancer. It could be investigated because it could be malignancy, or existing neurological deficit. So it could be any sensory alteration or bladder dysfunction or any other neurological deficit, which we normally meet when we investigate neurological patients. So the next question, which always appeared, it's which modality could be used for the investigation of acute low back pain. So we all know that the 1% of people have the imaging of the degenerative disease of spine. So it's 1%, and every year young patients have additional percent of this degenerative disease, bulging disc, low height of the disc, and it's completely not correlate with the pain syndrome, especially acute kind of syndrome. That's why the choice of the investigation, of course, moving to the possibility to investigate soft and bone tissue. That's why we, as the sample we can see the modic change 30 years ago, 35 years ago described. And by the way, the posterior location of modic change much more painful than anterior location. So the having the degenerative change created by modic, we can see the stage of degeneration, the lines of degeneration, and finally effectiveness of therapy, because it could be reverse of the modic change from third or second point to the first. Another decision regarding question which investigation is worth to perform. Also, we see in this big paper, it's understandable that they compare the results of the patient which was investigated by CT, and it mostly patient which couldn't be performed MRI because of metal construction and the prosthesis, etc. And it's always seeable that's the proper filling which actually doesn't work, which actually the changing in spinal canal we can see. It's for example facet joints cyst, and it could be seeable on the CT scans. So the same here, the real situation which provide the neurological status for the patient could be more clear investigated if we can see the facets with like here cysts, or is it disc bulging as normally can perform and can lead the neurological deficit. And also it's just it's not low back pain, it's let's see cervical myopathy, but situation inside the spinal cord, like this picture of snake eyes. It's also could be investigated and done only with using MRI. Finally, there are some modalities which described by Vakar with his algorithm to recommended as the first choice using MRI and correlated with neurological deficit if it exists, if it's some indication that a patient can have instability, a tumor or bone structure disease. It could be additional CT, and some signs of instability can be performed with flexion extension radiological, rentgenological investigations. At least many papers, hundreds of papers, is compared the different investigation from the point of view of low back pain. Mostly, you can see it here, it's one of the biggest articles, 1,000 cases. Mostly, they showed that the myelography with CT only indicated in case if MRI is contraindicated due to metal in the body, and not any plain films investigation indicated as a first investigation for the patient with acute pain. At the same time, there is some literature result that CT scan also in some cases indicated, but it's all, of course, the second choice when the metal couldn't give possibility to perform MRI, or CT scans. It's investigation which not need so much time, less expensive. It could be performed without local anesthesia because it's very short time, etc. The last question, actually, if there any correlation of radiology and back pain and some limitation of and side effects of the high quality modern imaging. I should say that the presence of the imaging in case of the we have acute low back pain is quite critical, because we are still didn't know if the accuracy of CT MRI is really have the reliable results, and very much diagnostic accuracy for all CT, myelography, or MRI, indicating very large proportion of false positive and negative results. That's there are many papers which showed us these statements, and very important that that should be some decision of the physician to perform investigation, because sometimes the patient have downstream, so many one investigation provoke another investigation. It's sometimes even investigation which could be performed with puncture of myelography, etc. So it's very important to keep selective approach for imaging and avoid unnecessary radiation exposure and some new, not reliable information for the patients, because the main idea now, and this paper is very looks like very reliable, that effects of imaging in case of acute low back pain is quite low, because no differences between routine imaging and usual care. It means that you couldn't change the structure of the treatment, having the investigation, if you do it just to know what's happening in, because it's 90% is non-specific pain. You wouldn't change the treatment, but you have a lot of impact for the patient mind, because in future he restrict all the physical activity. And I would say that it's somehow like system of yellow flags for the patient, because having in mind that he has back pain and some changing which probably not connected with his status of his back pain, and if he has some change in MRI, he will somehow reduce activity, social support. He will be in low mood, depression, etc. And that's what actually finally the negative impact of the investigation, which is not indicated for the patient with acute back pain. So finally, I'm going to the statements. First, I also subdivided for 3 groups. When to order radiological investigation in case of acute back pain. Patient with acute back pain having completed conservative management with persistent radiculopathic symptoms or severe progressive neurological deficit or signs of symptoms that suggest a serious or specific underlying conditions, including cancer, infection, vertebral fracture, and Cauda-Equina syndrome, indicated for diagnostic imaging. So it's unspecific by pain here. That's the first.
Patients which do not have this are called. It's not clear what is the completed conservative management. If there is no reflux, if there is no infection.
Everything is here. I mean, here's the, if acute back pain we have, we exclude all the provocation, infection, fracture, and if it exists, we have to perform investigation. If not, we don't need to do it.
I would suggest to delete this sentence may stay, but the completed conservative management can be deleted.
So we don't need to perform. I mean, it is the question. We have 4 weeks. It's acute back pain. If we perform conservative treatment or not. If we, if first doctors start to perform treatment, and if it's muscular pain and it's disappeared, what for he needs investigation. But if he perform and pain still exists, so he have to do it.
I don't think there is a good evidence in the literature, and in my practice, I don't see any patient that this low back pain has not subsided after 4 weeks. I am ordering the MRI. I don't do it.
So your suggestion to delete conservative management?
Yeah. But if there is radiculopathic symptoms, let's make 2 statements. One, patients with specific symptoms have to undergo radiological diagnostics. Yeah. Patient with failed conservative management or the treatment is always. Yeah. So they are talking only about acute back pain.
Yes.
Because of that, if it is a chronic back pain, and then we can order the pills, there is any surgical option, like severe modification, it's also 6 months. But it is acute back pain, and it's not clear what is the completed conservative management. Not there. So can we say my idea to reverse it was like that? So patient after did you change the thing? Isn't what I have.
Yes, I try. It's not my computer, but I can.
So my idea was patients with acute without symptoms does not require.
Slide.
Okay.
Or may not require. That's what I was.
So the suggestion with persistent.
So we make 3 statements. Like acute low back pain with specific symptoms require diagnosis. Yeah. Acute low back pain without the specific symptoms, but do not require radiological diagnosis. Acute back pain without significant, without specific symptoms, but with conservative treatment may after started after right after surgery. Well, conservative treatment you can just do 6 weeks. You not stay there. 1, 2, 3. Open it up. What happens?
One minute.
Okay. So make number 1.
I changed already.
I think that's good.
So finally, patients with persistent symptoms, progressive neurological deficit, Okay.
Patients, what would you say? How we went by should be 1, 2, 3, 4. That's just one thing. Let's put all 3 in one. Otherwise, we have 6. That's 8.
I would be astonishing if we have to perform investigation without treatment, any treatment, frankly speaking.
Patients with acute low back pain with specific symptoms should undergo neurological diagnosis. Okay, then maybe I double this slides, do 3 slides of it, copy it, then we make 3 statements. Somebody will read this. 200 questions and statements. That's what I'm interested in. I mean, you copied the slide.
Yeah, I just like this, like, yeah.
No, I mean, to copy the slides, and then we make 3 statements. Then
New-
one more statement.
Do we need to make a new slide? Insert
Yeah.
a new slide here.
Come on.
They want, obviously, radiology is very important, so they want more
Yes, of course.
statements.
I
Can you
suggest
copy
two.
all this slide like this? You need like this?
Just show
And then, so then statement 1, what did you say?
It's 2 points here. It could be a neurological deficit or unspecific pain, which could be malignancy or fracture. So it's have to
What do we call it? Specific
Yeah.
symptoms, or what is
be
that?
serious specific underlying conditions, including cancer
With-
injection. It's second part.
Yeah, but persisting is not good, like radiological? No.
Radiculopathic.
Okay, let's do it like this. And oh, this is horrible here. Nobody knows. And shall we include this?
Mhm.
Do we include this serious underlying conditions? Hey, guys, don't talk too much. Nicolay, do you agree with that? This is statement 1. We added the underlying conditions. Is that okay? This is statement 1. Okay, then you vote now. How does that work? Oh, whoa, 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 whoa. It's very difficult with this computer.
You can vote.
Okay, now statement 2. Is that right? Okay, statement 2. Where's
Statement.
Imad? We have to copy this.
I will preserve it. Okay, statement 2.
Make 2 over here.
It's first
Yeah,
one.
it's 2 now. It's 2 now.
Okay, let's do it like 2. Mhm.
So what is 2? 2 is, what is 2? Patients with non-specific symptoms in acute back pain do not require radiological diagnostics.
But we should not make it very strong because there is still margin for error there. So
Then let's do initially, with the initial presentation or whatever.
for patients without specific symptoms, a radiological investigation may be postponed.
That's very weak. Guys, you have to listen. He's making our statement so weak. What happened now?
No, he didn't.
Where's that?
Can
Oh no, this you cannot change anything. This is impossible. Don't do that. No. We have to change it.
No, to the last
Don't
one.
use the presentation. This is not possible.
We preserve 2 slides. It's okay.
No,
Is this-
where's statement 2?
At
You made 2 already. There's 2.
yeah.
This is 1. This is 1 we did. So then this is 2.
Chapter 5.
Let's do this 2. This is 2.
No screen.
This is not good. I better give you my laptop. But then I cannot do anything. I have to listen all the time.
Okay.
Okay, so what is
So
the
watching.
statement? When we don't have to do radiological diagnostics. Now you have to listen. We have to make a common statement. In the acute phase of low back pain, without, or what would we call it, red flags or whatever, there's no need for radiological diagnosis. Is that okay?
Yes.
In the initial phase, without treatment,
I think you needed circulation. So maybe in the case of acute back pain without neurological deficit, immediate radiological diagnosis or diagnostication.
No.
Not necessary.
okay.
Well,
Immediate radiologic imaging is not necessary.
we have to in one statement conclude all the
This is
situation
not a
which can
statement, this
happen.
is
It's
a-
not statement. Yeah.
This is a
We have to. That's why it's so long, because we have to take unspecific back pain, which everything, tumor, malignancy, and another with neurological deficit. That's 2 situations.
Define what is specific and what is not specific, and then just put specific.
Yeah, red flags. Red flags. It was 5th slide. That's what my
so
idea.
patient with initial presentation of acute low back pain without red flags does not require radiological diagnosis.
So we
Is
have
that
to
fine?
we have to translate what red flags then.
Well, red flags are defined. We
We-
don't
we
have
have
to do
to put
anything.
the-
Yeah, but you can look this up. Is that okay? So what is the, you try, write it?
Yeah, it's in there.
Yeah, but it's not, we have to delete everything. So,
It's another 2 statements.
okay, with initial presentation of acute low back pain and without red flags.
Why don't you change specific symptoms with red flags? Specific symptoms is
Okay, you want specific symptoms? Is that better?
No, red flags is good here. So what's mean red flags?
It's the same, but I think red flags are better defined. That's why I wrote red flags.
age, for example, is not specific, is not red flag. But if you have acute back pain over 50, it's quite suspicious for.
This is not a red flag.
So what do we do? I think red flags is very clearly defined. This is why I prefer red flags. What is the audience? Red flags. So we skip this again. I think we skip lunch. So first presentation maybe like this. Initial. Is that okay? What do you think? Patient with first presentation of acute low back pain and without red flags does not require initial radiological workup. Hey guys, not only drinking. Dr. Zippel. Agree? Mehmet? Okay? We delete all this because this is the next one. Now you can vote on this. Vote on this. This is statement 2. We had statement 1. Now we come to statement 3. Oh, this is so slow, this laptop. Wow. Okay, so what was 3? 3 was failed conservative treatment, right? Patient with failed conservative treatment. And then what was the statement?
Maybe consider for imaging on the 6 weeks.
4.
May
Acute is 4.
or Mehmet, can you agree with that? It's very weak.
So I'm going.
Is that okay? They have 4 weeks of acute low back pain, and then we do imaging. And we do not screw the doctor because it's not a major fault to do the imaging. I think it's okay. I think the statement is fine. Everybody agrees with that? Okay, it's a difficult task. Atim, I'm sorry for this.
That's okay. Thank you.
Okay, so next one.
I will have another. Oh, sorry.
Did you vote? Did you all vote? 1, 2, 3. Now we're with 4. What?
Should we consider?
No, maybe. This is not should be because Mehmet doesn't do anything. Maybe. There's no clear evidence if you have unspecific back pain that you have to do anything. I mean, when you look at the guidelines, you can even don't do anything. It's still okay. But you might miss some prostate cancer metastasis or something. So I think it's good with this, with maybe. Okay, statement 4.
Also very long. If decided to perform imaging for acute back pain patients, MRI is usually preferred. We can also subdivide it, but I think it's okay because it involves no radiation exposure and has better soft tissue contrast resolution. We can share it, but it's CT scans provide superior bone detail in case of vertebral fracture or MRI contraindications.
I would just stop after preferred dot, and that's it. The statement.
What?
Preferred dot, and all cancel all the delete all the
Because okay.
Because it's not need.
I
Cancel
understand.
no need.
Yeah, because
We
okay.
do MRI first way of treatment. Is that
Okay,
right?
agree. And then CT scans. Yeah.
Everything else you just delete.
Everything. CT
Everything
scans
just
also.
delete.
But if a patient with metal construction, so it's understandable that MRI is better.
If it's a contraindication, you don't do MRI. So is that something we can agree with? Okay, you make a lot of statements. I see that. So copy this again here.
Okay, this one.
Francesco, it's so much now. It's good.
I do it like this probably.
No, copy. The copy the slide here. This one. Copy. Paste. So then we have
Okay.
this 4. So statement 4 is preferred or recommended. I think recommended, huh? Is recommended. Usually we can delete, recommended. You agree with that? Yeah, and then we are with statement 5.
Did you vote for the 4?
Did you vote for the 4? And CT scans provide superior bone detail in case of vertebral fractures or MRI contraindications, but are not as useful in depicting extradural soft tissue pathology such as this disease. It's an okay statement. Okay, we vote for statement 5. And now statement 6.
The last one, and short.
6.
There is strong evidence that routine imaging for acute back pain by using radiograph or CT MRI is not associated with a clinical benefit on patient outcomes. Theoretically, we can finish this. Diagnostic imaging studies should be performed only in selected high-risk patients because it's somehow repeating of the first statements.
No, it's different. This means rather that we should avoid diagnostics in patients who are not, you don't know about the psychological influence.
Leave it
of
like
the
this.
disease. I think I like it.
Okay.
What do you
Voting.
think? Shall we vote?
Is it contradictory if we add a clause here saying that with a clinical benefit of patient outcomes and can reveal incidental pathologies? Because we are trying to recommend many people what will happen with
I would go further, Mehmet. It's not incidental pathology. It's nothing. It's physiological degeneration. So we all have these patients. They come and they tell you, well, I have 3 disc prolapses, and they don't have anything. So I think it's not, if we name it incidental pathology, that means that's a disease. If we name it incidental findings without pathological worthing, it means it's physiological.
we can change the term, but then he mentioned a good paper telling that it show the diagnosis.
It's a very good paper, I think, very good.
Yeah. We must add something here.
Okay, so what?
On that, because then people recommend.
No lunch. So there's strong evidence that routine imaging for acute back pain, then let's skip this to make it shorter. Routine imaging is not associated with a clinical benefit. Okay. Benefit dot, delete. Diagnostic imaging studies might reveal incidental findings without pathological value and should be performed only in selected higher risk patients. Is that okay? Everybody agrees? Then vote on this statement number 6. Okay. So a particular applause for Artem. I think that was very difficult.
Thank you.
Okay, Salman, you're next, I think. Okay. You just save it. Okay. Good.
So the reason I disappeared just now was because these guys saved the old file and then added the new slides onto it. So the whole thing was destroyed completely. So just trying to sort that out. So it's at least, I think it's sorted. This presentation is actually by Ian Block from South Africa. He's a WFNS Spine Committee member. Unfortunately, he can't be here because of some family issues. So I'm going to present. There are a lot of basic stuff in it. So I'm going to skip some slides because we are really short of time and this is not a teaching class at the moment. ये फाइनल यही वाली है तुम तो दूसरी वाली Are they voting? But can they vote? Are they voting? So guys, if you can hear me, who's connected? Do you know who's connected? So if you can hear me, then you can vote. Takashi. Okay, I think we're going to carry on. We're running late. And the role of drugs, medicines that we use in back pain and sciatica. ये काम नहीं कर रहा है क्या आप लोगों का? साइड से ऑन करके दो ना मुझे यार. So acute back pain, role of medical treatment. So this presentation was made by Ian Locke. I've made some changes last night and this morning. And have to go through it quickly. So 1,170 hits, English only 1,140. Relevant to our topics 534, review articles 101, randomized control trial 61. PubMed, maybe 1/3 of those were from PubMed. So the question was that what is the best medical treatment, when to initiate medical treatment? And these are the results on the research that we did. And this is how we went about it. So it's too small for us to see, but eventually this is what we had: randomized control trials, prospective, retrospective, and review articles. So what analgesics should be used? If we looked at that, these were the hits that we got. So I'm just going to move forward with that. This is the same thing. Eventually you get with RCTs, prospective, retrospective, and review articles. And when to prescribe opioid drugs. So we put in back pain, opioids, and this is what we got. And what about muscle relaxants? So this is the results we had for last 10 years. Very limited. I think does bed rest mean the best conservative treatment? What should be the duration of bed rest? So these were the hits. What about the sick leave? This is what we had. So background, we already know about it. I'm going to move forward. The list of medicines that we will discuss is paracetamol, NSAIDs, opioids, pregabalin, antidepressants, muscle relaxants, and steroids. So paracetamol, don't need to know the action. Those are not going to. The important thing is contraindication, that we should be careful with people who have got hepatic failure, renal insufficiency can cause problems. So just need to be wary of that. So current NICE guidelines from 2016, paracetamol should not be used alone for managing low back pain, but rather in conjunction with a weak opioid. So you've got a mixture of some kind of opioid to go with it. So other guidelines, Belgian and other guidelines recommend the use of paracetamol in acute lower back pain along with some other drug. So Williams had in 2014 had a double-blind randomized controlled trial. Paracetamol is regular or as needed dosing did not affect recovery time in patients suffering from acute back pain. So patients who got it and didn't get it, the recovery time was same. So there wasn't a big benefit of using paracetamol. So this systemic review by Shahid in 2021, 36 previous systemic reviews into this, and he showed no benefit for treatment of acute low back pain. So you're talking about acute low back pain alone, not talking about sciatica. So paracetamol doesn't help in any way according to this RCT, this meta-analysis. Literature, pain as a symptom, paracetamol works. But if it's centrally acting nature and not anti-inflammatory, then it will not affect acute low back pain. It will support other first-line interventions such as exercise, yoga, acupuncture, palates, etc. But it will not work on its own. So the question, should paracetamol be recommended in acute low back pain? And should it be the first-line secondary drug? So we'll answer that later on. NSAIDs. Used for the following properties: anti-inflammatory, analgesic, antipyretic. Not going to go into that. And it's basically inhibits cyclooxygenase. COX-1 versus COX-2 inhibitor. COX-1 is described as housekeeping enzyme. Gastric protection. COX-2 is described for brain, kidney, and bone. So NSAIDs, if you look at Cochrane review from 2008, 65 trials, with 102 to 11,000 patients, and they showed statistically significant in favor of NSAIDs. compared with placebo, but the cost of statistically significant was there were more side effects in patients who had NSAIDs, and we know that. There is moderate evidence that NSAIDs are no more effective than paracetamol for control of back pain. Paracetamol was, however, noted to be having fewer side effects. COX-1 and COX-2 together for back pain. So COX-2 is a selective agent with significantly fewer side effects of COX-1 and COX-2. So again, they repeated this Cochrane in 2016 and said the RCTs have failed to show a significant difference in pain relief between selective and non-selective NSAIDs. NSAIDs consistently shown to be better than placebo therapy. Question, again, NSAIDs should be recommended in treatment of acute low back pain. Should they be first line? Should we give selective COX-2 inhibitor? So let's go on to then opioids, and I'll answer this at the end. There are a group of national, I'm not going to talk about what they do and what are they responsible for and how they work. Mechanism of action, we talked about, it works in the brain in different types of fibers, and which results in analgesia. And it has a reward system, so there's inhibition of GABA in it that can help us. Again, tramadol, oral atypical opioid, maximum dose 300 and 400. Current NICE guidelines say there is no evidence in the use of opioids in acute sciatica or chronic lower back pain. Only consider if NSAIDs are contraindicated, not well tolerated, or ineffective. So if because of whatever reason you can't give NSAIDs, then only use opioids, otherwise don't use opioids as a routine. They must be regulated, and in US it's a big thing these days that people are worried how much of opioids are we giving. Should we be giving them routinely? So we're going to answer all these questions. So hang on, what are we doing? So in the event the opioids are prescribed, should tolerance, dependence, and withdrawal be discussed with the patient? So all those side effects should be discussed. So evidence recommendations, according to us, no benefit over conservative measures for acute low back pain and NSAIDs for radiculopathy. It is indicated when only first-line medicines are contraindicated and not tolerated. So we can think about all the side effects of NSAIDs, and if somebody has those problems, then obviously then you use opioids. Pregabalin, mechanism of action is still unclear. It binds to alpha-2 delta protein subunit of voltage, gets a calcium channel blocker, and site of action is cortex, olfactory bulb, hypothalamus, and other brain structures. Those I'm not going to talk about. And then it can be given in acute or chronic sciatica. So randomized control trial, 209 patients, 80% had pain for 3 months. No difference found in pain, disability, or quality of life. So patients who had it or did not have it, there was no difference. Then there was another study from 2015, prospective clinical equivalence trial to evaluate the effect of pregabalin and opioids in management of neuropathic or nociceptive chronic pain. Pregabalin shown to be more effective in patients who suffer from neuropathic pain and lower extremity. We are talking about chronic pain. So in chronic pain, it was found to be more effective. In acute pain, it did not have that much benefit. So they looked at this, again, chronic low back pain associated with leg pain here. And they found that these patients treated for 4 weeks improved with both pain measurements as well as pain-related sleep interference. They also looked at the Rollin-Morris scale, and they found the score to there will be a clear difference in patients who had pregabalin versus who didn't. 10% of these patients defaulted treatment due to adverse effects. In the initial pregabalin trial, 1 in 3 patients defaulted because it used to be really high dose 300 milligram trial. And so about 1/3 of the patients dropped out of the trial. Here, 10% dropped out because of adverse side effects. So you need to be wary that pregabalin has significant problems in various areas. And then pregabalin again looked at a meta-analysis between 2007 and 2017, and they showed that there was no evidence for the use of pregabalin in acute back pain, chronic non-radicular pain, no effect, radicular back pain. So 3 poor quality studies which showed mixed results. So in back pain, it's quite clear the pregabalin does not have a role itself. So if we ask these questions, pregabalin is not recommended for managing acute low back pain or chronic low back pain alone. Although pregabalin has mixed results in acute sciatica radiculopathy, it has shown to have beneficial effects in neuropathic leg pain. It has shown mixed results for chronic sciatica and radiculopathy. Muscle relaxant, so the types of medicines are benzodiazepine, and then we have got antispastics, and then you have benzodiazepines itself. So it's currently the third most commonly prescribed medicine for lower back pain. Today, US guidelines recommend as drug of choice for lower back pain. So they use, it's the first line drug for lower back pain. In Belgian guidelines, it discourages the use of muscle relaxant. UK guidelines shows no recommendation saying that there is no difference between the two groups. So if you feel like using it, you can use it, but they think that there is not much benefit using or not using it. So 2015, meaningful reduction in acute low back pain. The problem was there's overestimation of the impact as the data registry was not considered in this particular study. Systemic review and meta-analysis from 2021. It was a small trial with no conclusive evidence as shown at the bottom. Benzodiazepine evidence, patients with acute, non-traumatic, non-radicular low back pain, no added improvement in functional outcome of patients when diazepam was added. So if you've got sciatica or no sciatica, the outcome is same if you're using diazepam. Should non-benzodiazepine be recommended for the treatment of acute low back pain? Well, the answer is then evidence is inconclusive, but non-benzodiazepines medicine may be recommended for spasm with acute low back pain. There is mixed evidence that benzodiazepines as muscle relaxant works for acute back pain. It may be used selectively to reduce severe spasm and pain. So let me come to the statements. So now let's see if people agree.
These are new statements. I don't have them here.
Yeah, they're new statements.
I would suggest instead of making different statements for each drug, we can make one statement involving all drugs.
Okay, actually
We don't need that much.
So all the guidelines have taken every medicine separately because their mechanism of action is different. Obviously, now our first statement is, for example, that there is first-line medicine, the usage of advanced age, GI problems, cardiovascular, renal conditions. That's where you use it. It is not recommended when NSAIDs are present. So it's quite.
Also, I think depends a lot on the discipline the patient is referred.
Yeah.
So for neurology, there's not a single patient without prevalence. They all get this. They have sciatic symptom, neuropathic. Doesn't matter. They have low back pain. They all get prevalence. So I think it's good. My opinion.
Because everybody else has got the similar kind of, they have also looked at various medicines separately. It's just that the advantage, for example, what's the advantage of paracetamol versus NSAID or disadvantage? So, because somebody is prescribing paracetamol all the time, somebody is prescribing NSAID all the time.
Let's go faculty raised by arms. Who's for separate or who's one statement? For one statement. One statement. Separate.
Okay. So we must say that recommendation, paracetamol is recommended for acute low back pain. First line use in patients is recommended art. So you can fix it later on. As a support for the opioid. It is not recommended above NSAIDs as first line drug. And maybe we can remove the last line. Okay. Is that all right? Can we vote on this?
What is that? It is not recommended about.
So it's NSAID is the first choice. That's what you're saying.
Let's just delete it.
Okay, just delete it. So because we are talking about NSAID anyway. So statement one, let's vote.
This means that paracetamol you only give opioids.
You only give with opioids because.
Somebody who has a gastric ulcer.
Yeah, who has got all these symptoms?
Don't give paracetamol. I wouldn't give
You can give it. We are not saying that.
No, you're saying that.
No.
Support in opioid use. Then delete the last sentence. It's only is recommended as a support in opioid use. That's what you're saying.
So the studies have only shown this. The paracetamol on its own has never been shown to be effective with acute low back pain.
Paracetamol on its own, it has never been investigated.
It has been investigated, but they found no benefit.
Make the statement, there is no benefit.
Yeah, but people generally use as an adjunct. They don't use it alone. So you use paracetamol and use a muscle relaxant to go with it. So if you have
This is only paracetamol in opioid use.
yeah, but idea behind is that if somebody's got GI problems, then you don't give them NSAIDs, then you can give you opioids.
The treatment tactics was not involving opioid or just saying that
Can we bring it back?
Go back.
Just undo.
I know. It's gonna say it's not.
So let's delete this. This is fine. Let's delete this sentence and just say that, yeah, delete this sentence, please. And just say either alone or as support. So, people use alone or as support to opioids. So although there's been no benefit.
That makes sense because otherwise you call it first line and use it only as an add-on.
No, we are calling first line only for selected group of patients.
Yeah. But if it's for selected group of patients, it's only an add-on.
Okay. So can we vote on this, please? Okay. Statement 2. First line drug in acute back pain radiculopathy. So just remove words at site of inflammation. So just and put an NSAID is what are you doing? NSAID, bring the NSAID down. In acute back pain / radiculopathy. Short course appropriate for both managing acute as a first line pain. If you can delete this sentence, please. Short course. Yeah, it's short course to here. Just delete the sentence. Just this sentence, yeah. COX-2 are preferred due to lower side effects. And remove the side effects business because we should know this. Is that okay? Can we vote on this? Statement 2. Okay. 3. Opioids have no benefit. No, delete no twice. Over conservative measures for acute lower back pain and NSAIDs for radiculopathy. It is indicated when first line drugs are contraindicated or not tolerated. What
is missing is that they have severe pain.
Exceptions are never in a guideline. It's actually, all the studies have shown that it's of no benefit. We can write it because we think it's right, but the guidelines, there is no evidence. That's the problem.
Well, it's not give opioids in a patient who is crying because of pain. Instead of placing it with parenthesis, short course.
Okay, so we can write that instead of no benefit, we can say have limited benefit. Or conservative measures for acute back pain and NSAIDs for radiculopathy. Yeah. And you can say that a short course of steroids may be tried with patients with intractable pain. Yes? A short course of steroids may be tried in patients. Okay. Okay.
That parenthesis over there, the third row, short course.
Short course. Yeah, remove. The short course is good. I like short course. Otherwise, people give it for long term and they're hooked up on it. A short course of steroids may be administered instead of tried, may be administered. Oh, agree? Okay. Mehmet, can we put that short course back, please? Is that I don't, maybe considered is a better word. Yes, Mehmet? It's just that, we see these patients who are on steroids for 6 months, opioids for 6 months, and then we can't take them off. It's a big problem.
We never use opioids.
Same here. We rarely use it, but Germans need it and Americans need it. Those two on that side, and those three on that side. Listen, you give them water, you try them water in an injection, and you try opioid. It would work. You'll see. Let's have a trial for all our centers. Okay. Statement 3, can we vote, please? Have you voted? Okay. Statement 4. So pregabalin is not recommended for managing acute low back pain or chronic low back pain alone. Alone. No, because okay, you're right. Just remove it. Patient does not have sciatica. No, it's actually both the studies have shown that in chronic low back pain, if it's only chronic low back pain, then it doesn't work. If it's sciatic or the pain radiating down in the leg, then it works. So it's neuropathic. Without leg pain. Without reticulopathy. Yeah, okay. Can we vote, please? Okay, next. So this was this, although pregabalin has mixed results in acute sciatica radiculopathy, it has shown beneficial effects in neuropathic leg pain. Pregabalin has shown mixed results for, so just delete this. Delete the second statement. So just delete this one. Why do you want to delete this?
Because we make a consensus that acute lumbar pain, not on sciatica. This is the statement maybe for this.
Okay. Okay, so delete statement 5. No, since the medicine was there, so that's why, but you're right. Okay, so although the evidence is inconclusive, but non-benzodiazepine medicines may be recommended for spasm in acute low back pain. Okay, myorelaxin.
What do you mean with
Non-benzodiazepine are all the other forms of muscle relaxant, like you have got something like Ternalin and all that kind of thing. Somebody. Because the papers, I showed you the papers. Yeah. Myorelaxant, yeah. Yep.
That's better. That's better. But we have non-biased benzodiazepine myorelaxants.
So you have to say non-benz and just medicine and non-benzodiazepine.
Yes.
Okay, can we vote, please? Okay, so statement 6 then. Myorelaxants, yes. And benzodiazepine we have to correct later on. Just remember we have to correct. Okay. 6. So we make sure you do this in the end. You are the moderator, man. You do this. Okay. So I don't know. You want to have a statement on benzodiazepines? There is mixed evidence that benzodiazepines as muscle relaxant work for acute back pain. It may be used selectively to reduce severe spasm and pain. Is this okay? You want to vote on this, Mehmet? Okay, let's vote. 5 statement. So 4, 5, 6. Okay. Okay, next. Who do we have next?
Yes, sir.
So next speaker is Emmett. Acute back pain, role of physical therapy and rehabilitation. Yeah, the issue is just sending the message. Can you give the lecture? Or should we postpone? Do we have?
We cannot postpone because our thing goes.
Can you do it? You have it on your computer or you want my computer? Do we have a permission for Zoom? Because I think Thatched was.
Yes, we have.
Yes, we have, and we have already sent them links.
Email liya kya?
Yes, email.
Everybody has email.
This one?
Yes.
So we cannot. So
Thank you.
Hello, everybody. This is the presentation prepared by Dr. Yeşim Kirazlı, who is a physical therapist, physical medicine and rehabilitation department of my university. These are the questions she created to answer, especially acute back pain, bed rest, lumbar support, physical therapy techniques, exercise programs, and at the end, back schools. First of all, non-pharmacologic conservative treatments of acute pain, back pain can be with bed rest, lumbar support belts, exercises, instrumental physical therapy models, manual therapy, and other modalities. And to answer the first question, she collected some papers for the bed rest for acute low back pain. This studies says that the further studies are required to determine whether bed rest has any place in the management of patients with radiating leg pain and radiculopathy. So it's not very consistent results to advise a bed rest. What about lumbar support belt? But in very short term, it may be helpful, she says. Maybe less than 5 days or a week long. What about lumbar support belts? There is limited evidence of efficacy of lumbar support for treatment of low back pain. There is also a lack of methodology in the studies and no standardized usage of the braces and the duration of the braces. This study from 2009 is saying that lumbar belt wearing is consequent in subacute low back pain to improve significantly the functional status, the pain level, and the pharmacological consumption. This study may be useful to underline the interest of lumbar support as a complementary and non-pharmacologic treatment. This is another study from 2019 saying that the restoration of functional disability was slightly better or augmented in the brace group. And in conclusion, this study results suggest that the effect of elastic abdominal bands appear to be more of a temporary neutral alteration of trunk muscle coordination, and with some trunk muscles becoming more active and others less, and not a case of uniform deconditioning as it is suspected. Are they harmful? Instead of being beneficial, do they give some side effects? One of the reviews says that it did not find conclusive scientific evidence to suggest that orthosis results in trunk muscle weakness. And another study from 2017, no negative effect of the continuous use of lumbosacral orthosis for 1 to 6 months. However, the quality of evidence ranged from low to very low. What about exercise therapy? And there are different types of exercises. So there are Mackenzie therapy, stabilization exercises, strengthening exercises, stretching exercises, and aerobic exercises. So there is no harmony between the studies. These different types of exercise therapies differ in one important aspect: the hypothesized underpinning effect mechanism. Some have a rather solid therapy theory, physiology, for example, aerobic exercise, while the others have a more conceptualized theory, for example, Mackenzie therapy, influenced by the persons that introduced that particular type of exercise therapy. This systematic review from 2020, effects of exercise therapy in patients with acute low back pain. Is actually, even the name is very sounding. The exercise therapy was categorized into general exercise therapy, stabilization exercise, and Mackenzie therapy. They have divided in 3 groups. No important difference in pain or disability was evident when exercise therapy was compared with sham ultrasound, or nor for the comparators usual care, spinal manipulative therapy, advice to stay active, and educational booklets. And neither Mackenzie therapy nor stabilization exercise yielded any important difference in effects compared with other types of exercise therapy. In systematic reviews, treatment periods for the exercise therapy groups ranged from 3 days to 8 weeks. Frequency ranged from 1 of 3 visits per week, 1 to 3 weeks per week. Additional home exercise frequency ranged from 3 times per day to once every hour. So it's very variable. So then comparisons are not healthy. So this study from 2020 saying that there is insufficient evidence that a self-directed Mackenzie exercise program for acute low back pain results in different outcomes compared with usual medical care. This study from 2018 concludes that the guidelines provided inconsistent recommendations on exercise therapy for acute low back pain. What about the other physical therapy techniques. One of them is the transcutaneous electrical nerve stimulation, TENS. It may provide by stimulating of the skin, pain decrease. However, there is insufficient evidence to guide the use of TENS for acute low back pain. This is a meta-analysis with 381 RCTs, 24,000 participants. And there it says that there was very low certainty evidence of the TENS estimate suggesting the risk of adverse event irrespective of severity compared with comparators. This study says that the presence of pain rather than medical diagnosis may be improved by TENS, and the researchers encourage guideline panels to consider this evidence when evaluating TENS in the future. The findings support best practice guidelines to advise patients to self-administer strong, non-painful TENS within or close to the site of pain, and to adjust pulse frequency, duration, and pattern to what is most comfortable. Patients are advised to administer TENS as often as it is necessary. What about cryotherapy and thermotherapy? There are different studies making these to differentiate the effect of those. This is another one for the acupuncture. And this study says that a significant difference in therapy effect favoring acupuncture was found for pain at less than 1 month, 1 to 3 months, and 3 to 6 months, as well as in quality of life at less than 1 month, and on functionality at less than 1 month and 1 to 3 months. So acupuncture had beneficial effect in acute low back pain. Yeah, this is a systematic review and meta-analysis concludes that the acupuncture treatment for acute low back pain was associated with modest improvements in the VAS score and the number of pills. And this 2020 study, again, a multi-center interventional study, says that the acupuncture treatment provided in this trial consisted of both shorter treatment time and fewer treatment sessions than usual treatment. Again, I can skip some of the slides, and this is 2015 study that's saying that in physiotherapy, massage is considered as an adjunct therapy or a complementary treatment to prepare the patient for exercise or other intervention. It's rarely the main treatment used. Massage should not be the main treatment used. So this is the guidelines of American College of Physicians from 2017. They recommend that given that most patients with acute or subacute low back pain improve over time, regardless of treatment. This is, again, we must stress on our recommendations. Clinicians and patients should select non-pharmacologic treatment with superficial heat, massage, acupuncture, or spinal manipulation. But the quality evidence is low. Although it is not evidence-based, some guidelines included massage in the treatment of acute low back pain, just as it is the case of exercises. This is systematic review and meta-analysis saying that spinal manipulative therapy was associated with statistically significant benefits in both pain and function. Manipulative therapies may also help And this is, yes. What about back schools? There was a trend in the past using back schools to increase the frequency of acute low back pain attacks, but it's probably a better implementation of chronic back pain, not acute low back pain. So although Yeşim has prepared some literature, it's uncertain if back schools are effective for acute and subacute non-specific low back pain, as there is only very low quality evidence available. So we can not say that it is effective in acute low back pain. So the question for the first question, what is the place of bed rest in acute low back pain? Recommendation maybe we recommend to avoid bed rest in acute back pain. Staying active leads to better symptomatic and functional outcomes in both the short and long term for people with acute low back pain. Let me take my computer. Can we please open the Zoom on the TV? So then we let Yeşim to talk. And then let her to talk. Yeşim, can you please unmute yourself? You must unmute yourself. You are muted. Okay. Okay, we can hear you. Yeşim?
Mute. Okay, now it's all
yes.
right. Because you have to let me to get connected, but now it's all right. I had some problem with the connection, and thank you for the presentation of me.
Thank you for connection. Yeşim, unfortunately, I have to present your slides.
Okay.
Okay. And then now the more important is that we came to what the recommendations.
Mm-hmm.
Do you hear us?
Yes, I hear.
Yeah, okay. The first recommendation was this. You can see on the screen.
Mm-hmm, yes.
And are there any questions from the members? We can just vote. Did you also open your voting screen, Yeşim?
No, because I had problem connecting from my computer, so I borrowed another computer from someone else, and I couldn't do the Google form. Google form.
Okay.
But my answers are these.
Yeah. Okay, we voted for this.
Okay.
Question 2. Question 2, what is the role of lumbar support belts in acute low back pain? Is there any negative effect? Sorry. Lumbar support belt wearing slightly augments the functional status and the reduction in the pain level. There is no negative effect by the use of lumbosacral orthosis in means of muscle weakness and deconditioning. Yeah. Yeah. But we, come here, let's make together, yeah. Actually, this computer is not working well. I cannot place it.
If I escape, then we go out. Yeah. So I don't know what happened. Okay. So number supposed to remove bearing. I don't
couldn't
like this
make it.
computer. Yeah, I hate this. This is why. Where is the math gone? Can we get the math, please? We say may augment.
May augment the functional status.
That I have.
But it augments
may-
slightly.
And
We can probably we can say we may reduce the pain level and augment
may
the
reduce the pain level and augment the functional status.
functional status. May
But
reduce
it's slightly.
may reduce the pain level and augment the functional
Full
status.
stop.
Is it okay, Yeşim?
No, but you should add also slightly.
Slightly.
Mhm.
May and slightly.
May is fine.
May is fine, I think.
That's what it is.
Okay, okay.
There is no negative effect by the use of lumbosacral orthosis in means of muscle weakness and the conditioning. This is fine, okay?
Okay.
Any contradiction? Oh, okay, good.
I just think that it should be information that raise reduce the amplitude of movement.
Reduce what?
Amplitude of movement. Limited the movement. That's probably the reason why it's it's only psychological.
But then now we are saying as a result of the literature. Yeah. We are not very sure. We don't stress much actually. We say may, and then there is no negative effect. Is somebody is telling that wearing a brace, lumbar brace may have side effects by muscle weakness.
Yes, but there are very good 3 studies which are saying that there is no effect. They have used EMG and they have done recordings.
It's not orthosis.
Is it a lumbar orthosis or just a belt?
No, orthosis.
They ask.
And there are
Orthosis.
one study is done with belt and the other one is done with orthosis.
Maybe we can just delete about orthosis and not talk about it because it's let the physiotherapists, etc., make their guidelines. We just take the first part as.
Is it possible that we change instead of lumbosacral orthosis, saying lumbosacral support?
Okay, I'm again, looking at the literature,
Let's see.
one is done with elastic lumbar support belt, support belt. And
This
the other
is not a real
is lumbar belt. Okay, you
orthosis.
can say, you know, lumbar support belts. Lumbar support belts, we can say, not to use the orthosis. Elastic lumbar support belts. We can use that word.
Good, good. We are voting
Okay.
recommendation 2, and then now came to 3. Thermotherapy and cryotherapy are efficacious on relieving pain in acute low back pain. Applying supplementary methods, especially application of thermotherapy, could strengthen the efficacy of pharmacologic treatment and minimize the pain.
So can we just leave it just one sentence and remove this, because we're saying the same thing.
Same thing, almost, yes.
Remove these lines. No, just
Let's go up.
yeah. And then
TENS may be beneficial for the reduction of pain in acute low back pain, as it should primarily be indicated according to symptoms. That is the presence of pain rather than medical diagnosis.
so just maybe we can. We need to remove this until here.
Until here. Here also?
Yeah.
There's no risk or
Full stop. That's fine. You can, or you can delete it.
leave it. Okay.
Okay, let's vote.
Let's vote then. Is there another?
That's all.
Is it? What? How do you go?
If you guys vote, then you will
4.
think about it. If you don't vote, then you'll be thinking about something else, birds and rain and whatever.
There is low to moderate certainty evidence that exercise program of all kinds does not result in different outcomes compared with usual medical care. Let's say there is no effect.
So the bottom
In acute back pain.
is better.
No evidence in favor of prescribing in acute. Let's say in acute back pain, there is no.
Just leave it.
Yeah, come on. Yeah. It's awkward. The computer. Delete the first one. No. Stay. Yeah.
The second sentence is better, I think.
Yeah, there is no evidence in favor of prescribing exercise programs in acute low back pain. Good. Let's vote.
And 5.
A systematic review of the literature yielded no studies to adequately address this question. What is the question?
So we say to address timing, frequency, and duration. So
Of treatment with exercises.
Copy paste it.
Timing,
frequency, and duration of treatment with exercise.
copy. No. Yes, good. Exercises. Appropriate should stay. Appropriate should stay. Appropriate should stay. Timing. Yeah, treatment of exercises. With exercise, with. No, it.
It's not in English, in English. It is something.
What about this? It's just.
What are you saying? Just go back to what it was initially. Just go back.
Açalım. Again.
Just remove the question fine. Just say statement, recommendation fine. Patients undergoing treatment, just as it said, patients undergoing treatment for low back pain. What is the appropriate remove? Timing, frequency, duration of treatment with exercise, undergoing exercise treatment. So exercise treatment. And comma for low back pain, comma. The timings, frequency and duration of treatment with exercise. So what was the thing? Shows, showed, what did it show? No benefit.
No, educate.
What about this perhaps?
Yeah,
is
go
it,
back
but
to
it
what it
just
was.
goes.
Go back to original and just let's go to the question alone.
Let's go back and just, okay, it's fine. Go back, go to 5.
5, come
Just
to 5.
make a
5.
vote. Yes. Make a vote and delete everything. It was good before.
It was like this.
We can redo it, but it's otherwise we really it's too.
Yeah.
Yeah, so
We will add this sentence.
so
Yeah,
let's
okay.
vote. Question 5.
Let's go, next one.
So sorry, Yeşim, this is our,
Okay.
this is our way of making.
Okay, good. And 6.
Go to 6.
Yeah. Manual therapy and massage. Sorry. Spine manipulative therapy may provide short-term improvement in patients with acute low back pain comparable with other standard treatments. Massage is more effective than an app.
So let's remove the second part and just vote on the first part.
Massage, but massage and manipulative therapy are different things.
There's no evidence for effect of massage. This is the second part. Just make it short.
Okay, that's fine. So that's fine. Just leave it there. Leave. Let's vote on both of them.
Yeah, let's go on.
Okay. 7. Let's go to 7.
Number 7.
Role of acupuncture. There is moderate evidence of benefit of acupuncture with significant effects in respect of pain intensity.
Okay, that's what.
Next
Go to
one.
the last.
Again, we must add acute low back pain in each
We have
recommendation.
to remove.
Back screws are not an intervention to be used for acute and subacute low back pain. Yes. This is, I think,
Back screws.
these are very nice recommendations.
Very good. Vote.
Okay.
Yeah, we thank you.
Thank you very much.
Thank you.
Yeşim.
I really thank
She's-
you, presentation, for the invitation.
Very good.
Sorry for disturbing you from there.
It was a nice experience for me also. Thank you very much.
Yeah. Thank you, Yeşim. See you later.
Thank you. Bye.
Goodbye.
We have to go down. We're not allowed to do it. We are back. This, what time is it here? Is it 18 now?
Yeah.
What is the time?
It's 11:20.
It's 11:20 now, so we are.
Just
here
give me
at
one
11:30.
thing. Your boss is,
Sharp. Who's not here? We will close the door.
your boss is on me. So give me 2 minutes.
Yeah.
You must be so tired. I'm relaxed.
Okay. So you want to connect your laptop or you want to give my? Okay. Yeah. Totally possible. साकिब भाई इनका यूज वो कनेक्ट करिएगा
Yes, hello, thank you very much for this short introduction. My name is Christoph Sippel from Homburg, Saar, Germany. This little hospital here and this sleeping gentleman, I think you know him all, is my boss. I have 4 questions for the epidural injection in acute back pain we want to address for this talk. The first is, are epidural injections recommendable? Recommendable in patients with acute back pain without major neurological deficits? Where exactly should epidural injections be made? What are the optimal agents to be injected and which complications to be expected? These 4 questions shall be addressed by the talk. And what we did is we looked in PubMed, Google Scholar, Scopus for publications of the last 10 years for a full access manuscript. And we took only prospective controlled randomized trials addressing the above mentioned questions. So after all, if you hit the search topic epidural injection and back pain, you get 1,600 hits in PubMed, for example. But in fact, only 4 of them of the last 10 years were randomized controlled trials evaluating their effect. These were Inverson, Cohen, Nadini, and Abinin who addressed this topic. And what they did is, in fact, we have epidural injections of acute back pain patients. In the first line, you see Inverson with some steroids and saline as a control group, also epidural injected, and a second control group with epidural with subcutaneous injection of saline. And interestingly, they found that at 3, 6, and 12 months after the injection, there was no difference in pain relief between these groups. So there was no real treatment effect anymore, at least. Cohen et al. Did quite a similar design in their study. They had epidural injection of a steroid, they had saline injection and of an anti-inflammative agent. And they found that epidural injection after 1 month of steroids is superior to at least the sham group. Nadini et al. Had 2 groups, one with steroids, one with saline. And after 12 weeks, there was no difference in the effect. And Abedini also had a controlled trial with local anesthesia, with steroids, and with saline again. And they also found that they found that steroid application and local anesthesia is superior to their sham group, in fact. So in conclusion and in summary, we can say there are quite a lot of good trials, and especially I want to emphasize here the first one of Inverson et al., where they showed that there is no effect of epidural injection of steroids compared to the sham group of saline injection after a certain amount of time, 3 months, 6 months, 12 months. So saline works the same, at least at these time points. Conclusion, all these studies showed a significant decrease in pain after injection, whatever they injected, compared to prior to injection. At least on a short-term effect, maybe steroids might work better than anything else. On the long run, the data show that there is no effect of any of the injections, neither steroids nor saline or anything. And there's probably quite a magnitude of placebo effect in this. Second question was where to inject epidurally. And there are 3 sites, in fact, you could do that. One, you put the needle in the midline. One, you do it on a parasagittal interlaminar approach, and the last one on transforaminal. And then we also looked again for controlled trials who evaluated these sites. In the last 10 years, there were in fact 6 controlled trials analyzing this question. And starting with the first one, they had only 2 groups, one in the midline and one parasagittal injection. And they showed that pain relief is bigger in the parasagittal injection than if you do it in midline. And this structure goes throughout all these studies. If you do the injections more laterally, either transforaminal or on the parasagittal interlaminar approach, pain relief is significantly increased compared to if you do the injection in the midline. So conclusion, the more lateral approach nearer to the root is probably better for pain relief when you're looking for the injection site. Third question was, what will we inject? there are different options like steroids, like local anesthesia, things like that, and even some biologicals, these Anacept, if you looked at the second study I introduced in the beginning. There were quite a lot of studies regarding that in the last few years. And altogether, you can conclude that on a short-term effect, the particular steroid use, so steroids are in a particular form, are probably better than non-particular. No, the effect is probably similar of particular steroids versus non-particular steroids, but in a longer run, the particular steroids are probably better well, maybe that's not clear from literature, but due to their dissolving effect that they give their agent longer into the space and therefore have a longer effect. And third one, the complications arising from epidural injections. We have to see here that the studies are a little bit heterogenic because sometimes these studies only include those side effects which are correlated with the medication itself, but not with the puncture procedure. So some studies decide between these two and do only mention the side effects arising from the medication, in fact. So the numbers of side effects I show here are probably on the lower side of effects, but maybe there are more in studies where these puncture side effects are not reported here anymore. But what you can see in total is if you look at the rates of complications, they are quite low in the end. And if you look at the descriptions of the side effects which may occur, they are not of an lasting effect and more like dysesthesia or a dural puncture or things like these things which have usually not had a really long lasting effect. So that in conclusion, we have to say that there are, of course, quite a variety of complications arising from different medications of different puncture techniques, but they are usually not lasting. And in general, epidural injections can be considered a safe procedure after all. Coming for voting, for the first questions, are epidural injections recommendable in patients with acute back pain without major neurological deficits? I would state statement 1, epidural injections showed a significant decrease in pain compared to baseline before injection. At least on a short-term effect, 4 to 12 weeks, steroids seem to be superior to placebo, and no evidence for a long-term benefit of steroids versus placebo can be found in literature. And there is considerably quite a magnitude of placebo effect with injection techniques.
So there are a lot of patients in there who have discontent superiority. I think at least the pain, part of the pain is because of the swelling. And of course, at least, so I don't like the results of the evaluation, but I think this is the thing. Then I think we should. Why don't we put it there? Why don't we put that? Yeah, but this is just a question. This is not academic. Then we make a statement, still with these statements. Difficulty with the injections, low back pain. For instance, show significant decrease in pain.
Yeah, the point is, Joachim is absolutely right. These papers and the cohorts in them do not really stratify between a clear lumbar back pain and the one with lumbar back pain with maybe particular pseudoradicular symptoms. Yeah, so I'm quite sure that there are also patients who have this. Can you give me Yeah, so they can work with it. Duplicate. Yeah, well, you have to differentiate here between acute back pain and the lasting effect of the therapy, which is here 4 to 12 weeks. But this is not the time the pains occurred. Yeah. Yeah. Well, if you look at this, at these studies, you saw quite well that if they injected just some saline or they injected steroids, this made, at least on the long run, no difference. And there were also some studies who showed that if you inject, for example, steroids as well as salines, and they could not see a difference here. So I think, and this is also my personal, thinking, that if you put a needle into a bag and this bag has some pain, alone the placebo effect of the procedure leads to a reduction of pain. There, I'm quite sure about. Yeah. Yeah. Well, we also have to address.
We have to work on low back pain. So the difficulty in low back pain was that also the majority left basically low pain.
Yes.
So they don't do a very good diagnostic work. But anyway, we have to deal with this. So I think the best way is statement before our questions and answers. Then we have to do agree with this content. Yeah, but we need what people do.
Yeah. Thank you, Professor Sharif. Second one, where exactly should epidural injections be made? And a more lateral and therefore nearer to the root approach seems to be superior to a midline approach. Well, it's been, in fact, multiple studies showing that.
Well, this is a big issue. There are several studies showing that it's not midline, and some show transfemoral, and most are called lateral. So this is why I think.
Well, the explanation, well, there is a little explanation, in fact, in literature, and they're showing here that this ramus dorsalis, which is awaiting here the facet joints and the origins of the acute back pain, in fact, is more hit by an injection on the lateral side and less on the medial side. So this is maybe the anatomical explanation for it. Well, this. Yeah, in fact. Good.
Maybe you should be able to, I think this makes sense. A more lateral approach seems to be severe. Let's try to explore that because that we have
Okay. 3, what are the optimal agents to be injected? Statement 3, short-term effect below 1 week is probably similar between particular and non-particular steroids. Longer lasting effect, longer than 1 week, probably with particular steroids. Well, crystalloid, I'm not sure, well, the English word for it. They are both are steroids without any doubt. Yeah. The one is, for example, some dexamethasone as a non-particular and non-particular. Non-particular. Then let's call it just dexamethasone. Okay. This is in fact the word from the literature, yeah. Delete brackets. Okay. And statement 4, which complication is to be expected? There is a variety of potential complications. Potential complications are usually not lasting. In general, a safe procedure. Yes. Puncture. Yeah. Yeah. Okay.
I think what you refer to is that you check the local anesthesia. They all from that it's not neurological deficit, permanent deficit. It's not a there is cases where you sometimes that they inject let's just remove the statement at all. I think stenosis and you inject epidural, this is a disaster. People don't look at that. That's really complicated. If we get even there, but let's say prevention complications are not lasting. But we can add. Potential complications are usually not lasting. That is relief potential. Right complications are usually not lasting, but severe complications are strong. Yeah. So many of them. So that's usual. Complications are not lasting, but severe. But there. But if we have a PCI, okay. Let's say that.
If we just delete the first one, so let's make it complications are usually not lasting, but severe complications have been described. Mm-hmm. Francesco? Adjusting.
Just put rare before severe and then put
Rare before severe.
rare but severe complications.
Okay. Where are you? Thank you.
Yeah, but they want it. So just say they are usually not lasting. Just say they. Remove the complication, just say they. And we don't have to very well. They are. How about the standard? Okay. Now it's good. So what now? That's what. That was the last one?
That was the last one.
Perfect. Yeah, brilliant. Excellent. So we move on. Very good.
Thank you.
Good morning. Acute back pain, Pheasant blocks, and thermal ablation techniques. Another important topic. I thought we had it interesting because think about it. You will save that, send it to your company. As I told you, all I was asking Did you send me? Why not? You have to do it now.
So thank you for the invitation and also for the topic that is very far from my neurosurgical practice. So it was a chance to study. Joaquin, can I start? Okay. No, please. Okay, so a very brief background about the pathology, very brief. So lumbar facet joint syndrome is a unilateral or bilateral back pain syndrome with the radiation to one or both buttocks, side of the groin and thighs, and always stops above the knee. It lacks of clinical specificity. Since this pain can mimic a different pain, for example, caused by lumbar disc herniation or root compression. History and physical examination may suggest but not confirm the symptoms and also the syndrome as a source of pain. What we do know? Chronic low back pain in general is one of the most common pain with enormous burden for society, and lumbar facet joint syndrome constitute a common, very common source of pain. But to date, it remains misunderstood, misdiagnosed, and sometimes improperly treated. We know that there is no effective correlation between clinical symptoms and imaging of the degenerative spine abnormalities driving to this diagnosis. The social impact is very high. As you see, also is a very expensive disease due to different factors like lack of diagnosis, imaging overuse, sometimes surgery not working, and also working stoppage. This is a brief review of the anatomy. The lumbar facet joints are the only pyramid and the arthroidal joint of the spine. They serve for stabilization segment of the segment, both inflection and extension. They also rotation movement. Capsule, subchondral bone, and synovium are very innervated by nociceptive and autonomic nerve fibers. And the main point is this one. Each joint is nervated by dual supply for the medial branch. You can see my mouse there. Yeah, that is the target for both blocks and also radio frequency. How facet joint can cause low back pain? The main reason is the osteoarthritis. This is the most frequent cause. It's characterized by loss of joint space, narrowing, loss of the synovial fluid, and loss of cartilage and bone overgrowth. There are other reasons like spondylolisthesis, septic facet arthritis, trauma, inflammatory condition, and also osteoporosis. From a clinical point of view, as I said before, it is characterized by local pain and also pseudoradicular radiation with a different distribution, and claudicatio can be present. The pseudoradicular lumbar pain radiate uni or bilaterally to the buttock and the trochanteric region, the groin and the thighs, always ending above the knee without neurological deficit. But the radiation sometimes can also reach also the foot, thus mimicking sciatica pain. Pain is usually worse during the morning, during the period of inactivity and following stress and exercise. And from a clinical point of view, it's very important that because this pain can be elicited also by palpation. Different diagnoses come up to triatica sciatica, true sciatica, pathology, and or sacroiliac pathologies. So lumbar facet joint syndrome seems to be not a reliable clinical diagnosis, and a specific etiology of back pain can only be diagnosed in 50% of patients based only on clinical examination. So imaging as a role, this is a question. We can perform plain radiography, CT scan, MRI, and also nuclear medicine technique. Radiography sometimes is enough because it's able to suggest just joint space narrowing, subchondral sclerosis and erosion, cartilage thinning, calcification, hypertrophy. All the things are also seen on CT scan, but compared to plain radiograph, offer high contrast between bony structures and also the adjacent soft tissue. MRI can be of help because is able to show in T2 frequency, T2 images edema, especially during the acute inflammation period, and expect with a 99 technetium labeled with biphosphonate is also to show osteoblastic activity due to the increased uptake, even this is not very specific. So the role of the imaging in facet joint syndrome is still under debate. This is why, because osteoarthritis, this is the common cause, is often seen in 24% of people before 40 years. And this percentage is increased to 89% in people between 60 and 69 years. So there is a strict correlation between abnormal morphology or radiological findings and back pain. So the interest of imaging always lies in its ability to rule out a different diagnosis. So this is a very short flow chart for the treatment. So can be conservative or interventional, like using block that's used for diagnosis, and then ablation. Conservative is based on the use of medication, physical treatment, also some information about the habits of the life. The block. Controlled block are the only reliable tool for the diagnosis of facet joint pain as cause of low back pain. Sometimes a definitive diagnosis may require 2 blocks in separate sessions. And here there is a short video just to show you the technique. The facet joint injection can include the use of long-acting corticosteroid that they are able to provide anti-inflammatory and affect immunosuppressive action, inhibition of neural transmission within the C fibers, and also the use of local anesthetics. Thermal ablation. We have 3 choices, but the last one is not used anymore. We have the heat, so the radiofrequency, that is most used technique, and also the cold, the cryoneurolysis, that's used less than the first. So the 2 most widely used technique are radiofrequency and cryoneurolysis. Neurolysis does not allow a definitive pain relief. This technique destroys the nerve that can eventually regenerate with the recurrences of the pain. So the procedure can be repeated, of course. The radiofrequency technique emphasis is made on the electrode placement that must be parallel to the target for the denervation. So radiofrequency probes produce transverse lesions around the electrode, but this effect is very short, very small in the tip of the cannula. So perpendicular placement may miss the target nerve. This is not true for cryoneurolysis, where the approach can be also perpendicular. So we performed a review of the literature in the 10 years, and we found a lot of papers. Most of them have been excluded because they didn't match the English language, not related to the field. There were case reports, retrospective studies, technical reports, and have been excluded, and 24 catch our attention for the study. Question 1. Can history and physical examination select patients for facet joint blocks? So this is the background. The diagnosis of lumbar facet joint pain rely on the combination of symptoms, physical examination, and confirmation by diagnostic block. So correlation between physical symptoms is very important. However, considering the high percentage of false rate of uncontrolled facet blocks, they risk and cost are to be considered in order to identify the responders for this procedure. This is a very recent paper coming from the American Society of Regional Anesthesia and Pain Medicine Board of Directors that agree, saying that there is no pathognomonic physical examination or historical signs that can predict the response to facet joints blocks. So the possible statement, I will ask you to vote later. Okay, I will do a quick recap. So the possible statement of the question 1 is that physical senior symptoms are not related to response to facet joint blocks. However, there are some papers and there are some studies suggesting that clinical presentation is crucial to select targets for blocks. And the study also suggested that maneuvers associated with the radicular scenes may be predictive of negative diagnostic for facet blocks, because it is not facet pathology, but is another things like lumbar disc herniation. Question 2, is there any correlation between radiological findings and facet joint syndrome? Recent studies suggest that most widely used in modality imaging is the SPECT. This is a nuclear medicine technique requiring the administration of a radioisotope, and of course involves considerable radiation exposure. So SPECT scans can identify active inflammation involving, here you can see, the facet joint. However, although we said this, there are a number of studies suggesting that SPECT, scintigraphy, and CT scan that are used in conjunction with the confirmatory purpose have reported variable results. And this is the demonstration. This is a clinical study where patients received the SPECT scan, after which a physician blinded to the result, examined each patient, and patients received a series of 3 fluoroscopically guided medial branch blocks. And in conclusion, they found that compared with the diagnostic infiltration, SPECT CT scan showed only a moderate sensitivity and specificity, therefore not be recommended as a first-line diagnostic tool prior to diagnostic infiltration of blocks. And this is another study, less recent than the before. It was a randomized clinical study in which patients have been also investigated with the SPECT, and they found different conclusions, since a bone scan with SPECT CT was found to complement the clinical workup of patients with low back pain. So inclusion of bone scan with SPECT CT in lumbar pain management protocol can help in making a correct diagnosis. So there are variable results coming from the literature. So the possible statement 2 and the answer are the following. Overall, there is a moderate evidence supporting the use of SPECT for identifying painful lumbar facet joint prior to start with the block. Weak evidence exists supporting the use of SPECT for identifying painful lumbar facet joint prior to intra-articular facet joint injection. And for scintigraphy, MRI, CT scan, there is weak evidence supporting the use of this technique for identifying painful lumbar facet joints prior to start with the block of the facet. Question 3. What is the role of conservative treatment in lumbar facet joint syndrome? If any, how long should be continued before facet blocks? So the background said today there is no evidence demonstrating the appropriate timing of optimal duration of conservative treatment. So timing duration should be customized according to individuals' characteristics. The North American Spine Society and the American Society of Regional Anesthesia and Pain Medicine Board of Directors suggest that failure of at least 3 months of conservative therapy could be considered important before starting with diagnostic joint blocks and nerve ablation. So 3 months of failure following conservative treatment that can be based on the use of medication, physical treatment, and so on. So the possible statement would be current research does not provide evidence regarding timing duration of conservative treatment for facet joint blocks. Question 4, are medial branch blocks preferable to intra-articular injection to select patients for thermal ablation? And should corticosteroid be used in intra-articular injection for therapeutic purpose? This was very important to me because I used just to do an injection, intra-articular injection. So I found that there are a couple of studies very important. One coming from Cohen that is always involved in this study. And in the study analyzed more than 500 patients will receive the radiofrequency ablation after either intra-articular blocks and the medial branch blocks. And they suggested that there is a higher success rate with the medial branch blocks compared to intra-articular injection. So I made a mistake during my career so far. So the diagnostic value of intra-articular injection was investigated in a blinded triple crossover study, and also this author concluded that a single intra-articular injection was not a valid means to diagnose lumbar facet syndrome. What about the use of steroid? There are a couple of studies, very recent study that suggests that it is not useful for therapeutic purpose. So possible statement to the answer to the question 4 is the medial branch blocks should be prognostic screening test of choice before lumbar facet radiofrequency ablation. And the use of corticosteroid has no evidence, but it can reduce, it can have a therapeutic value just when the denervation can be contraindicated. Question 5. Is image guidance necessary for lumbar facet blocks and radiofrequency ablation? So the background says that we can use fluoroscopy and CT, of course, because they help a lot and avoid complication for sure. And this is a study suggesting that maybe CT scan is better than fluoroscopy because it's able to indicate the precise anatomical osseo, the precise target compared to the fluoroscopy. And very recently, also ultrasound guided injection has shown to be effective in reaching the target and also useful in reducing radiation exposure. So this is also another technique that you can use. So the possible statement to question 5 is that the mainstay for guidance, image guidance relies on CT scan and fluoroscopy. CT scan is more precise. Of course, it's more expensive than fluoroscopy. Fluoroscopy has low cost, faster time, less radiation exposure than compared to CT scan. Ultrasound may be also useful in patients who radiation exposure is associated with the potential harm. Let's think to pregnant people, for example, or in patient treated in place where radiation is not available. Question 6: what should be the cutoff for considering a block as positive? Here, there are a lot of papers in the literature, and I'll try to summarize what I found. So the International Spine Intervention Society guidelines suggest that complete relief in a distinct topographical area is necessary for a particular block to be a positive. But what should be the percentage? The Initiative of Methods, Measurement and Pain Assessment in Clinical Trial guidelines suggest that a 30% or greater in reduction in pain can be considered a moderate clinical improvement. Overall reduction of 50 or greater can be considered a substantial improvement. So the possible answer to the question 6 is the evidence support a reduction of pain more than 50% to be considered a positive block. Of course, there are evidence showing that the result could be better when this cutoff go up to 80%. Question 7, which patients' radiofrequency ablation should be repeated and what is the likelihood for success? So pain relief after radiofrequency ablation is still a time-limited procedure. So in the current clinical practice, radiofrequency ablation can be repeated on pain recurrence. The average success rate of repeated radiofrequency is 80% in patients who experienced a good outcome from the first procedure, and the average duration of pain relief is about 10 months. So when response to the first radiofrequency did not meet the 3-month cutoff for a positive outcome, repeat radiofrequency is unsuccessful and then is not suggested. So the reply to the question 7 is a lumbar medial branch radiofrequency ablation of pain recurrence can be performed in patients experiencing a minimum of 3 months improvement for the first technique. Given the drop-off in success reported in some studies, the procedure should be repeated no more than 2 times per year. The last question is, what are the most common complications of facet joint intervention? So we can have vascular injury and also drug uptake, procedure-related pain and dysesthesia, injury to non-target neural structure, and also denervating surrounding muscles. And they also suggest that there could be also an interference with the spinal cord stimulators and even with the spinal instrumentation. This is very, strange to me, but is what I found. The vascular injury is the most common complication. We have an incidence of intravascular positioning rating between 30.7% to 20%. And vascular penetration may produce adverse effect due to the drug uptake, but also, this is most important, give false negative diagnostic block. So must be care about this. In the study, considering more than 300 patients with medial branch blocks, the author found 19 incidents of vascular uptake using digital subtraction, 11% using real-time contrast administration, and very few cases with aspiration. So aspiration seems to be not a good method to understand if we are inside a blood vessel. This is a sorry, my phone is ringing and disturbing me. We have also pain and dysesthesia following the procedure, but there are very minor complications and also are self-limiting. And sometimes the use of corticosteroid following the procedure may reduce this discomfort. So the statement, the answer is the following. So vascular injury is the most important complication, and checking for intravascular placement by spreading and visualization, the spread of the contrast on fluoroscopy in real time prior to perform medial branch blocks may reduce false negative results. Of course, patients must be informed for the complications. So before I come to this recap, I found that this is maybe it's better do in this way. So I just summarize the year so we can start voting. So can history and physical examination select patients for facet joint blocks? The answer could be, there is no evidence suggesting that physical symptoms are related to respond to facet joint blocks. However, clinical presentation can lead to patient selection for blocks. Radicular signs may be predictive of negative diagnostic facet blocks. The last sentence? Okay, I can delete the last one. Sorry? Yeah, I'm doing. Is that okay? Can delete this? Okay. Okay. Statement 2. Is there any correlation between radiological findings and facet joint syndrome? Overall, there is moderate evidence supporting the use of spectrum MRI and CT for identifying painful lumbar facet joint prior to medial branch block or intra-articular facet joint injections. Maybe we can delete intra-articular facet joint injection since we know that it is not effective live medial branch block. That could be, suggestion.
We have moderate evidence suggesting that SPEC, MRI, and CT ensures everything.
Yeah.
About third world country, Africa, as well, because these guidelines are installed for everybody.
Well, the question is if this
Yeah.
So the cost of the set off is and a needle, and it's basically cost of respect must be much higher. So I think it's difficult to recommend even if you do the injection and it doesn't work, then you know what's going on with the side.
But the question is, if there is a correlation between radiological findings and facet joint syndrome. Okay, for diagnostic. This is the reason of the pain. Okay.
Because I think it's very clear that aesthetic gives us, the activity. So it's very rare. Maybe let me modify the question that unclear cases, we take the issue that comes to work out, although it is not possible.
Okay. Is this? Okay. Yeah. Yeah, but as I told you before, the radiological investigation can help you to rule out differential diagnosis, so you can exclude other problems. Let's vote. So we have one disagreement. Okay, statement 3. What is the role of conservative treatment in lumbar facet joint syndrome? If any, how long should be continued before facet blocks? So the answer would be, today there is no clear evidence regarding timing, duration of conservative treatment for facet joint blocks. However, it has been suggested the failure of at least 3 months of conservative therapy can lead to diagnostic facet joint blocks and nerve ablation.
Not say for facet joint, for facet joint pain.
For facet joint, what? Pain. Okay. Or we can say directly failure. Okay. It's the same. Because 3 months is what the literature suggests. Yeah, yeah. Does that work? Okay. Can we go? Yeah, okay. You made me pressure, now you're losing time. Okay. Okay. Are media branch blocks preferable to intra-articular injection to select patients for thermal ablation? Should corticosteroid be used in intra-articular injection for therapeutic purpose? So media branch blocks should be the prognostic screen test of choice before lumbar facet radiofrequency ablation. Corticosteroid didn't show to reduce the need for radiofrequency ablation. It may have therapeutic value, inflammation, inflammatory fasciogenetic pain, and when the ablation may be contraindicated. Maybe we can reduce. Just leave the last sentence. Okay. So let corticosteroid. Okay. Okay. Is that okay? No, I didn't get the point. What you said.
Instead of that, we can say corticosteroids are not superior to the radiofrequency application. Now we do with ablation. Are not superior.
Did you vote?
Yes, please. You voted for carry on.
5. Is a okay, thank you. CT or fluoroscopy can be used for lumbar medial branch blocks. Ultrasound may be useful in patients whom radiation exposure is associated with the potential harm or when radiological imaging is unavailable. Six. Which should be the cutoff considered block positive, although there are studies showing the patient with more than 80% relief are more likely to have a positive response to radiofrequency ablation than those with less relief. A significant proportion of patients who achieve a threshold of 50% relief will benefit from radiofrequency ablation. Voting? 7. In which patients are radiofrequency? Okay, we can reduce it.
Actually, in this, we don't really answer the question. So the answer would be
the cutoff.
Is considered to be
the cutoff.
This would be the answer. Here, in the answer, we discuss pain relief and then whether it makes it to radiofrequency ablation. It's not the question.
Yeah. I think just simple sentence which you're saying that
50% pain relief is considered to be positive.
Okay, let's.
So it has exactly 50%. So just remove everything about 50%.
Yeah, I'm doing. Given the time. No, I just used the scene to say this.
Positive effect.
Will benefit. Let's. Yeah. Okay. Will be considered. Which patient's radiofrequency ablation should be repeated, and what is the likelihood of success for success? Lumbar medial branch radiofrequency ablation pain recurrence can be performed in patients experiencing a minimum of 3 months improvement following a previous radiofrequency ablation. So given the drop-off in success rates reported in some study and the mean duration of benefit, the procedure should be repeated no more than 2 times per year. We can shorten it, of course. Yeah. We can just say that the procedure, right? Should be repeated no more than 2 times a year. Okay. Okay. Last. About complications, so vascular injury is the most reported complications. Checking for intravascular placement by aspirating a visualizing to the spread of contrast on fluoroscopy in real time when performing medial branch blocks may reduce false negative results and adverse effect. Injection of steroid through the cannula after ablation can reduce pain and discomfort. Just aspirating?
Do we need this at all? Because it's what are the most common complications? These 4 are exact. Okay, so let's say most common complications of conceptual intervention are 1, 2, 3, 4. That's the answer.
I had to delete all the statement. I mean,
Oh, the statement is vascular injury.
yeah.
This is seizure. This is the, and the second part, just leave that.
Leave.
Second part, delete. Checking for
All? Okay.
What are the from modality? Okay, leave it.
Yeah, but just writing the most common complications, right? Okay.
Brilliant. Excellent.
Good.
This is your computer, Giovanni? Is it your computer?
We will see. Okay. Yeah.
Thank you very much. That was a difficult presentation.
Yeah, it was.
Very nice. Did very well. Next speaker is Nikolai.
Can I unplug here? Yes.
I think he has much easier.
Yeah, my presentation is
More difficult now.
my presentation is easier because it makes it easier. Also, the fact that I'm going after so many other presentations and we more or less cross cover. So. Okay. Okay, so acute back pain and the role of surgery. When, what, and why. So the objectives of that presentation is to give you some background, which most of that was given already, some definitions, clinical indications, implications, and consensus statement voting at the end. As usual, that presentation was done on literature research for the last 10 years. If you have to give you some background, very common, we all know that's a very common problem, acute back pain. As per the last statement of WHO with regards of this topic, everybody that's living now will at some point meet a spinal specialist by the end of their life. Second reason for sick leave after flu, third most common cause of surgery. So it's a pretty common problem. This is the situation in UK. About 7% of the population attend GP each year, and the cost, as you can see, is humongous. About 80 million working days lost. So we see a lot of patients, but as you can see on that pyramid, we operate not this many. So the reason for the acute back pain will be mechanical, degenerative in the majority of the cases. As you can see here, neurogenic problems will be the second cause, but way behind the first one. Non-mechanical spinal conditions, referred visceral pain, and other reasons are dwarfed comparing to the first two. So low back pain is defined as a pain that is back pain from the level of the lower rib down to the gluteal fold, with or without radiation to the legs. So if we see acute back pain, that we call that pain acute if lasts, according to some publications, 4, according to some publications, 6 weeks. The specific low back pain is when we find the pathoanatomical relations that can be demonstrated between the pain and one of the pathological processes, and respectively non-specific pain is when we cannot find that. Usually that pain is self-limiting. It will resolve in 6 weeks in most of the cases. As per the literature, more than 50% in 6 weeks. It will have high recurrence rate. Over 60% of these patients will return to work within a month, and over 90% will return to work in 3 months. So that is where the suggestion, and that's where the statement is coming, that the acute back pain is usually self-limiting, resolving in 6 weeks in the majority of the cases, and does not require surgical intervention. I'll flash that statement at the end so we can vote. Just recapping. So in case that was discussed before, I like this mnemonic. So for the residents, it's a tuna fish. If you have tuna fish, you have to explore further. So if you have trauma, unexpected weight loss, neurological symptoms, age, which is below 20 or over 50, and you have acute onset of back pain, if you have fever, if you have drug abuse, abusing patients, steroids, history of cancer, you have to explore further. But you can still see that the specific reasons for the back pain as per the literature is very limited cases. So that is why you still can wait in case you don't have one of these red flag symptoms. We have the second statement: in case of acute back pain, surgical options may be considered in case of specific reasons found on the investigations. This is a flow chart that I found. This is from the NICE guidelines. You can see that more or less they follow this as well. So initially you have to try to, frankly say, entertain the patient with different physical therapy, with acupuncture, with different methods, and you try to make the patient wait for the period of 6 months in case you don't, 6 weeks in case you don't have any specific symptoms. But in case you have specific symptoms, you have to explore further. As you can see, as per the NICE guidelines, there is no surgery that is recommended in the acute phase unless there is specific symptoms. So clinical implications of acute back pain, it was already mentioned that significant part of the acute back pain is coming from the facets, about up to 50% as per the studies. Cadaveric studies show over nearly 100% facet joint arthropathy in over 60%. We know that already from the previous presentations that there is no pathognomic tests. And so the injection is something that we will consider. We had a nice presentation that I will not repeat that. I just want to show you that paper that I mentioned previously. It just came. The current trend so far was in UK that you should not do injections for back pain or for even for leg pain unless this is a diagnostic test. But it looks like this is changing now based on the recent studies. This is a multi-center study that was published just recently. And that suggests that it is economically justifiable to start with the injection. And that will give many of the patients instant relief, as Joachim was advocating. And also that may divert a significant portion of these patients from surgery. So statements, voting. Acute back pain patient, acute back pain is usually self-limiting, resolving in 6 weeks in the majority of the cases, and does not require surgical intervention. Voted? Okay. In case of acute back pain, surgical options may be considered in case of specific reasons found on the interventions, on the investigations. And found investigations and clinical examinations. Okay. And finally, the third one might be duplication. Steroid injections could be considered in the treatment of intractable acute back pain after patient is investigated for specific reasons requiring urgent surgical treatment. Yes, that's why I said this is a duplication, so probably we can skip that. Okay, delete it. Short and sweet. I will.
We will skip actually the other topic. So this is the last talk on low back pain, acute low back pain. It's prevention of becoming acute low back pain chronic. Nikolai will give us the talk of the Sanjan from China. I don't know, is he online?
Well, I don't know. I didn't see him earlier. I don't know if he's now.
He was online, but I think we apologize that all the online presenters, we had to change the presentations a little bit.
Yeah.
All of them were.
So I hope that, yeah.
Next session, there's a couple of presentations I think by the we had to adjust a little bit. So I'm sorry for this, but there's no other way.
Okay, so we are thankful to, so the full presentation was very well supported by a lot of studies. Some of them were duplicated, which is good reinforcement, but because of time issues, as Joachim said, I have tried to reduce the paper, the presentation. So we are starting with definitions again. We know now what is acute pain. As per this questionnaire and as per the research, the chronic pain will be a pain that will continue over 1 month, or it could be over 3 months, but it has to be more than half of the days if it's 3 months. This is the definition for pain that is going chronic. So it's a pain that how we prevent the acute pain. That refers to preventing the transition from acute pain to chronic. And the pain is defined as pain problem that has persisted for at least 3 months and has resulted in pain on at least half of the days in the past 6 months. That's another definition. So there is definitions which are coming from different authors. They are not unified, but we all agree that the pain that continues more than 3 months could be considered as chronic pain. So chronic pain, however, is not acute pain that lasts longer. There is multiple mechanisms that are involved in the chronic pain. Apart from the fundamental pathogenic mechanisms, you have vascular mechanisms, you have central neuromodulation, you have psychological factors, which are actually very important. And hence the psychological screening is important when you have to predict if your patient will transfer to chronic pain or not. As I mentioned, the different and very complicated mechanisms involved, and part of those are not well understood. It's a multimodal pathogenesis, and that, of course, based on that, requires multimodal therapeutic approach. So chronic pain patients have to be treated by a team. So keywords and questions that were used: prevention of chronic back pain. And the first question that Zan is asking is, what are the risks of developing chronic low back pain after acute episode? And question 2 is, can psychological evaluation help us to differentiate patients who will develop chronic pain? Epidemiology: most of the people with chronic back pain will have in the past acute back pain symptoms and acute back pain episodes. The risk factors, of course, you have to have pain, you have to have psychological and behavioral features, like a feeling of catastrophizing, fear avoidance beliefs, maladaptive pain coping. Also, adverse life conditions are involved: smoking, cardiovascular disease, baseline disability, body mass index, obesity is connected to chronic back pain, physiological comorbidities as well. So how do we identify the risks? We have to try to involve non-pharmacological treatment with cognitive behavioral therapy and physiologically informed physical therapy. Again, the frontline options and the different problems which are involved in that research, you can see that sleep and sleep deprivation is important for chronifying of the acute pain. And hence, if your patient with acute pain is telling you that he's not sleeping, you have to work on that. And this is one of the mechanisms that will prevent the pain to chronify. Rehabilitation is important factor of preventing the acute back pain to go chronic. It is important to diagnose the pain and to treat the pain so the pain will not chronify. Again, early intervention in mobilization of the patient is something that is associated with reduction of the risk of the chronic pain. That's another way to say that physiotherapy will help to your patients. So statement 1, what are the risks of developing chronic low back pain after an acute episode? About 15 to 59% of the acute low back pain may transit to chronic. The risk factors of developing chronic low back pain after an acute episode include the
pathology of the pain, physiological and behavioral features, and baseline disability. Also, adverse life conditions, smoking, cardiovascular disease, body mass index, and physiological comorbidities may be included. This is the statement. It's a rather long statement, so I gather we have to work on it a bit. But we probably do that at the end. So the second question is, can psychological evaluation help us to differentiate patients who will develop chronic pain? And according to that research, it is important to evaluate psychologically the patients, and the psychological pain, psychological evaluation that is pointing patients with which are catastrophizing, patients with severe depression, patients with fears. They are potential chronic pain patients, and you have to have this in mind. Again, same research, different research, but same conclusions here. So the conclusion of the research with the which is treating chronic back patients and psychological evaluation. The most helpful component predicting persistent disabling low back pain, which is obviously chronic back pain, are associated with maladaptive pain coping, behavioral issues, non-organic signs, functional impairment, general health status, and presence of psychiatric comorbidities. So that was the first statement that we have to probably vote now, and maybe after we just amend it a little bit. 15 to 59% of the patients will develop. Let me just try to. Oh, something is not working. Yeah, but how can I get out of it? Okay, that's it. Thank you. And now that's it. Good. Now it's going to come back. Okay. So that first statement, 15 to 59% of the acute low back pain may transit to chronic.
I would suggest to place that percentages at the end of the sentence. Yeah, low back pain may transit to chronic.
Okay. Acute low back pain may chronify in 15 to 59%. Sorry? You haven't heard that word? No? Okay, I'll change it then. May become chronic. No, I say acute low back pain may become chronic in 15 to 59% of the cases. Okay, I'll remove that. Okay, the risk factors of developing chronic low back pain, obviously after acute episode, include pathology. Include the pathology, psychological behavioral issues, baseline disability. Baseline disability. Oh yeah, okay. Baseline disability, comma, and then small. Yeah. Okay, so.
Yeah, what is that adverse life condition?
Yeah, it's a very, very, very wishy-washy. Okay. Well, I think more or less there is tautology here because you say cardiovascular, body mass index, psychological comorbidities, all that, all this is. Okay. Yeah. Yeah. Voting. Save. I will send to Joachim immediately. Psychological evaluation will help. So just one statement then?
Chronicity is mostly
Psychological issues.
diagnosed by psychological.
Yeah.
We talked about gains. Chronic pain. It's like, you know, if I sit here and I sit down.
Yeah, that's the psychosocial, yeah, aspect of it. We haven't spoken with that, but I guess this is not the scope of, you know, this is something different. This is, yeah, this is back pain as profession. Who was saying, oh, Joachim was saying that in Spain, if you have back pain, you never work again. You know, you go say back pain and then they compensate you. Yeah. In Spain, if you have pain, then you don't work. Okay, so did we vote?
Psychological evaluation may help us to predict
whether the patients will develop chronic pain. Okay. The patients will potentially develop or will potentially develop chronic pain. Or whether the patients may, or whether the acute pain may transit to chronic pain. I don't know. All right. Okay, voting. That's it. Thank you so much. Yeah. No, you were complaining that it's too slow.
Do you know where the presentation is? Whether the last one or the one before? No.
So I do now. We switch now to this condition, which I think is
Yeah. Sorry. Yeah. Copy.
Don't push me under pressure.
Just put it
Although
there.
under pressure, I'm best.
So I have now the presentation. No, it's the other side. Okay, so before lunch, we have another 4 presentations.
You have to first of all tell them a joke.
No, I cannot tell them a joke because we will try to hurry up. So Francesco, you're gonna give Takami's lecture. So I will do Mirza and Mirza again. So Erika is now the first. So this is about, let me see, this is not the right one. This is the right one. So lumbar disc herniation, epidemiology and prevention. I have to say that Erika Bisson, she sent exactly at the time we discussed her presentation. It was very good. Then I just did some corrections, and she sent me the questions later on, and somehow I cannot find the questions. It was 3 questions, so I tried to do now 2. 1 is missing. I'm sorry for this, but the presentation is the presentation we discussed. So the presentation is divided in incidence, risk factors, patterns of herniation, and specifics for populations, and history of lumbar disc herniation. So there's a lifetime risk of symptomatic disc herniations of 1 to 2%. Important is symptomatic, because lifetime risk of asymptomatic disc herniations is much higher. Primary disc herniations resolve in about 90% spontaneously to some degree. And there's over 200,000 surgeries for lumbar disc herniation in the mid-90s in the USA. Erika is from USA, so all these data are from USA. This is almost all, not all, but almost all. So another, the sport publication, sports study. In this study, 30% of population experience a herniated nucleus pulposus prolapse in her lifetime, but not all of them had a specific symptoms. 60 to 90% responded to non-operative treatment with the resolution of symptoms. And the recurrence risk was about 9%, with 38%, so 1/3 of these 9% occurred within the first year of surgery. Then actually we had a little discussion about the definitions, and the protrusion is a base herniated component is wider than the most distant area. Extrusion, the base of the herniated component, is thinner than the most displaced area. And the sequestered area is a fragment detached from the disc. We in our textbooks in Germany use a little bit different definition, but she gave me actually her reference, and this is also missing because I don't find the questions. But so this is obviously in the States, this is a huge definition. I think it's not that important because we don't grab to it in the discussion. But the protrusion, we have a different definition, that the protrusion is an intact annulus, and then a prolapse is when the annulus is ruptured. So this is different here. We discussed this, and it was a good discussion. She gave me her reference, but I think I would just report this. It doesn't matter because we will not get to this in the statements. I think it's not important to really go to this. Yeah, maybe the idea is the same, but the wording is different. So lumbar disc herniation, and again, what the sports trial taught us: epidemiology of patients with lumbar disc disease. There were 1,417 patients enrolled. And the lumbar disc disease patients were the youngest, highest baseline pain ratings, and the most disabled. So they underwent chiropractic care. What was ED? She explained it to me. Emergency department, thank you. There's all these American shortcuts I was not aware with, so we discussed this. ED visits, huh? Is it from UK? Yeah, okay. Yeah, but it's the wording. So emergency department visits and opioid use was most heavily in lumbar disc herniation patient. And so the result of the study, there was a significant disability and healthcare utilization associated with the lumbar disc disease. Next study, this related radiculopathy is both biochemical and mechanical in nature. So we always discuss what is the inflammatory reaction around the sequester disc. And sometimes this is very important when you discuss this with the radiologists. When you go to the MRI and they give contrast, and then you see some contrast enhancing lesion, they frequently tell you there's a tumor. It's just a subacute disc herniation. So this is the inflammation around the vasculature around the disc herniation. Genetic and environmental factors play a role. There's strenuous activities and smoking are clear risk factors, significant risk factors, and genetic factors are related to collagen likely involved. Actually, we also did a study on this showing that when you did a spine procedure once, lumbar, then you're much more likely to have another spine procedure than, for example, a procedure for the hip or the knee replacement. Disc bulging and protrusion are common asymptomatic findings, and well, 60 and 36% of individuals are 50 years old or older. Most of the herniated discs occur in L4-5, L5S1. Improvement in motor weakness is in over 80% at 1 year. In the sensory deficit in over 40% at 1 year. And a resorption of the disc prolapse is in over 86% after 1 year. 25% have recurrent symptoms at 1 year. The conservative management has not shown faster recovery. Well, bed rest, lumbar traction, this is, now we talk about disc. We don't talk about acute low back pain. So you have to have this in mind that it's a different pathology. Well, actually, it doesn't make sense because how can you really treat severe disc, severe nerve root compression with bed rest? It will not help. Okay, so there's no evidence. The only thing I think where evidence is for lumbar traction is with the disc protrusion, but not with the herniated disc. So prevention. Data from epidemiological studies suggest lifestyle modifications such as smoking cessation, weight loss, and regular exercise may prevent sciatica or reduce recurrence, but there's no randomized trial available. Analysis of health insurance data to identify the distribution of symptomatic cervical or lumbar disc herniation. In Finland and Italy, there's a prevalence of lumbar disc herniation of 1 to 3%. It's higher for individuals aged between 30 and 49. And the male to female ratio is 2 to 1. Lumbar disc herniation in Mexico has a prevalence of 23.12%, very detailed. And 90 patients were involved in an exercise study. And it turned out that degree of obesity was no risk factor. Visceral fat area, yes, was a risk factor. So if you have a lot of fat in the visceral fat, this was associated with a lower odds of benefit from the therapy. Body mass index itself had no influence, and the abdominal circumference, because you have more visceral fat when you have a wider circumference, yes, was associated with a worse outcome. What we discussed this, I don't like the study very much because when you here look at the p-value, they're all very, well, they're not very clear. So, but this, she liked the study, so I will present it here. It's the degree of visceral fat area and abdominal circumference have a clear negative association with a recovery from lumbar disc herniation. Ergonomics and musculoskeletal disorders in neurosurgery, systematic review, meta-analysis of work-related musculoskeletal disorders were evaluated. 31% of surgeons with experience back and leg pain, and 23% was the surgical rate in this group. So it's a little bit higher probably than the general population. Here it says 6 times higher than the general population. I don't, this is, when I compare this when I get my feeling, I think it's probably a little bit too high, 6 times higher. So that means that health workers are more likely to undergo surgery. That's actually an interesting finding. So disc herniations in the National Football League. Retrospective analysis of the sports injury monitoring system registry data over 12 years. 76% of all lumbar disc herniations were in the lumbar spine in L5S1 most often. And well, I think I have no idea about football. So defensive linemen, offensive linemen, and linebackers are most often involved. I don't know what that means. Okay. Disc herniation in astronauts. I think this is a nice study. There's an increased risk of disc herniation in astronauts after space flight. They have 10% of them suffer from disc prolapse, so it's a high number. The highest risk is within 1 week after return to Earth. And the likely mechanism is that the disc is swelling is increased during the zero gravity and prone to herniation on return because of the sudden onset of the loading of the weight load. So now the statements, and this is the last slide I was about to prepare. Incidence. So statement 1, lifetime risk for disc herniation. Sorry about this. Wait. Lifetime risk for disc herniation is about 30%. Symptomatic disc herniation risk is 1 to 3%. 60 to 90% resolved spontaneously. Would you agree with that? Okay, now you can vote. Statement 2, risk factors. Both genetic and environmental factors are present. Strenuous activity and smoking are independent risk factors. Yeah. We can bring in the collagen. There's a subtype of collagen, which is likely that it's a genetic factor, but we said both genetic and environmental factors are present. Is that okay, or you want to change that?
Actually, I suggest you tell the risk factors for lumbar disc herniation are both genetic and environmental.
The collagen. I said it in the presentation. What is that?
Are there many studies about that?
There are a few studies, yeah. There are not that many because we prepared just to get a fund. So we tried to get a fund from the German Forschungsgesellschaft, but there are some studies suggesting this. It's quite obvious that you have a distinct type of collagen, you're more likely to have a disc prolapse. What? No, it's not. Yeah, it's one of them is Marfan, but they are very sick. Not only Marfan.
There is a family predisposition.
What?
The family predisposition.
Well, this is probably the collagen. Okay, let's say risk factors. For lumbar disc herniation are include I like include genetic and environmental factors, comma, oh, different size, strenuous activities and smoking are independent risk factors. Is that okay? What? Where should I stop? Okay. Good. Can we vote on this? Then patterns of herniation, I would skip. I don't remember that she had a question on this one. And then specific populations. We have just to go back that this is, I think this is that there's evidence that health workers are more likely to undergo surgery. Huh? It's not very controversial. All the studies who involve physicians showed that the physicians are more likely to undergo surgery than the others. There are 2 studies, I think. Yeah, they have access and, Shall we read it? So then let's just leave it by two questions, two statements. That's fine with me. I mean, we have enough. Yeah. Okay. Okay, then we're done with this one. And now I will go to this one. And I saw Mirza, I think he's online. Where's Imad? Can you check, is Mirza online? Because I have to apologize. I cut his presentation down from like 43 to, I don't know, 23. It's still a lot. Okay. Yeah, he was not able to come. So he sent me his presentation, and he also did prepare the second presentation from piriformis syndrome, presentation at 1 p.m. originally. Okay, so he's from Marburg, but he was not able to come for family issues. So what he did is literature review 2012 to 2022, randomized controlled styles, prospective study, retrospective studies with large number of patients, and he found 127 publications. Case reports were excluded, and he used also guidelines, various guidelines he used for his presentation, and landmark papers. I will not go into detail. Okay, so the thing is, how do we examine the patient for a clinical examination, clinical diagnosis of herniated disc disease? And there's no evidence for an isolated physical test. So we are back to the so-called neurological syndromes. So we have to evaluate muscle strength. We have to evaluate sensory. We have to evaluate LASIK or supine straight leg test, and usually the reflexes. There's quite a good study on this using the Cochrane database. And there's insufficient evidence if you use Braga tests, slump tests, bowstring tests, and so on. And well, there's also insufficient evidence if you have absence of reflexes. Absence of reflexes have so many different possible reasons, so it's not helpful, particularly when you think about that the lumbar disc occurs in 4-5 and 5S1. 4-5 is the peroneal reflex, and 5S1 is the triceps reflex. So these reflexes are very difficult to get, and frequently in the polyneuropathy patient, you don't have anything. So then pain assessment. Well, he pointed out that the pain assessment is very important. In my opinion, pain assessment has two aspects. One aspect is you need it for later on to see the effect of the treatment. For the diagnosis, I don't think that it's that important. And the other aspect is when the patient tells you, I had so much pain, you did not help me, then you can show him that he actually did on the visual analog scale, he only put a 4 or something. So there are different scores. We actually use only the visual analog scale, but it's important for optimal tracking of patient outcome to at least some assessments scale in the common clinical practice. So you should do this in all patients. So what is the difference between radicular and low back pain? Radicular pain is a clear radiation in one or both legs. And low back pain, facet joint pain, discogenic pain, muscle and fascia induced pain, you have not this radicular signs. So now I will go a little bit to that 2 or 3 slides, which I think are a little bit too much, but I was not, since he sent it yesterday, I could not change this. So facet joint pain is the result of a repetitive stress and cumulative low-level trauma, leading to inflammation and stretching of the joint capsule. And then you see, when you do the MRI, that was just what Giovanni pointed out, when you look at the MRI, you frequently see some fluid in the joint, in the T2. And the most frequent complaint is the axial lateral low back pain with the referred pain perceived in the flank, hip, and thigh. So it's a so-called pseudoradicular. So it's not radicular, not a nerve root compression, it's a pseudoradicular. So just some radiating, but not very clear responding to a dermatome. Well, there are no physical examination findings for the facet joint pain pathognomonic. And interestingly, at the end, we have a statement we have to discuss because it's a little bit different from the one we discussed earlier. The strongest indicator for lumbar facet pain is pain reduction after block. So then if you have a pain reduction after the facet block, it's very sure that this patient suffers from facet joint pain. Again, facet joint pain, how to diagnose and differentiate from discogenic pain. There's absence of pain exacerbation with cuffing, forward flexion, rising from sitting, hyperextension or extension rotation, then this might be not associated with a facet. Lumbar facet joint nerve blocks and the diagnosis of chronic lumbar facet joint pain have an evidence level of 1 based on 7 controlled diagnostic studies with 80% or more pain relief and 6 studies with the criteria standard of at least 74 pain relief. So overall 13 studies. For therapeutic intervention, there's level 2 evidence for the long-term effectiveness of using lumbar facet joint blocks and radiofrequency neurotomy. For the short-term improvement of 6 months or less, lumbar sacral intra-articular injection have evidence that is level 2. I will not go too much into detail because his topic was lumbar disc herniation and diagnosis, so I did not point it out at the statements. Discogenic pain involves degenerative changes of the intervertebral disc, including structural defects that result in biochemical instability and inflammation. Discogenic back pain and axial back pain are terms commonly used to describe back pain or surgery with an intervertebral disc degeneration without herniation, anatomical deformity, and other alternate clear causes of pain and disability. So how to differentiate discogenic pain from facet joint pain? Here's a very complex diagram, and I think I will proceed with the statements. Diagnostic criteria for discogenic back pain are provocative discography or CT discography. Well, are disputed now. We have done this in the beginning quite frequently. They are limited to patients. We still do this in transforaminal frequently. They're limited to patients who are planning to have a surgical procedure in the near future as a confirmatory step, particularly if you want to do a minimally invasive discectomy. Centralized pain and discogenic disease, whereas lateralized pain and facet joint pain has a higher head sensitivity, and non-invasive diagnostics type 1 modic changes in an MRI, high intensity zone in MRI on posterior annulus, and serum biomarkers are non-diagnostic modalities. Treatment, non-specific back pain, back exercise, or analgesia. I think I will just skip this because his topic was diagnostics. And now I come to statements. These are statements I formulated now based on his presentation. His presentation went on with a criteria for surgery and so on. I just deleted because we will focus on this with the next presentation. So radicular pain or sciatica shows a specific radiation of the pain in one or both legs and is usually connected to herniated disc. Low back pain comprises various symptoms such as discogenic pain, back pain, facet joint pain, sacroiliac joint pain, and myofascial pain. Can we agree with this?
Is it necessary to write something about low back pain?
No, we can delete it. You want to delete this?
Yes.
Oh. So shall we just do it like this? So that means statement 1, radicular pain or sciatica, we can just we delete this. Radicular pain, so specific. Is it like this? show specific radiation of the pain in one or both legs and is usually connected or associated maybe.
Let's close that on the right top, please.
No, I can.
You've got this extra bit open, so if you could close on the right top.
Okay. Is that statement one? Can we do like this? Good. Statement two is a little bit too long. History taking is obligatory and has to be done. And has to be done in patients. Has to be done, including questions on pain intensity, onset and localization. It needs to be assessed in one of the clinical scales or grading systems. This workup is rather of importance for further prognosis than for acute treatment decisions. History should questions on pain. This is what we have there. Pain intensity, onset and localization like this. This is rather what is that?
At the beginning, I would suggest to say the history is most important part of clinical evaluation, and it should include questions.
Very good, very good.
Just with history, we can decide everything.
Good, that's a nice idea.
Most important part
Oops.
of clinical evaluation
It should include questions on pain intensity, onset, and localization. It needs to be assessed in one of the. You want to leave this away? Shall we leave it like this? Is that okay? Where? Oh, yeah. Okay. Can we vote on that? Okay, very good. Because I'm almost through. Okay, next one. I don't know.
How are you, Visa? We can't hear you.
But yeah, this is. Let's continue. Really, we were so late. Okay, so statement 3, obligate diagnostic tests for use in physical examination of patients with suspected herniated disc. Radiculopathy, I think we can delete. Muscle strength testing, sensory testing, exclusion of bladder and anal sphincter dysfunction, as well as supine straight leg test, LASIK sign, and cross LASIK sign. I made 1 out of 2 because he had it separate, but I think we have too many, then otherwise we run out.
Obligate, we can say necessary diagnostic test. Essential.
Yeah,
Or
essential.
Yes.
Very good.
You can ask Mr. to smile so we can take a picture. Come back.
Is that okay? Essential diagnostic test for you in physical. Let's just do in patients with suspected herniated disc or muscle strengths. Is double. Diagnostic test is muscle strengths. Sensory. Evaluation of bladder and anal sphincter dysfunction. As supine, well, yeah, you want to leave supine straight leg raise, LASIK sign and cross LASIK sign. We can leave it. It's fine, but I don't think that we always do cross LASIK. I don't think so. Okay, leave it like this. Good. It's fine. Let's vote. Yeah, Mirza, you have to smile now because now you're yeah, we have a
okay,
picture.
thank you.
Yeah. Okay, next one. Statement 4, muscle strength testing should be examined in the Oxford scale, 0 to 5. I think it's good, although it's not that helpful sometimes, but I don't know. Then we call it MRC. No, that's just MRC scale. We do MRC. It's the same. Okay, statement 4, we vote. Then statement, oh, good. I missed 5. This is 5, sorry.
What did you do? You voted?
No, I put the one statement together with the bladder dysfunction. Now we're missing 5. Okay, so axial centralized low back pain in absence of radiculopathy, which increases under activity, is clinically highly suspicious of discogenic back pain. It might be accompanied by pain projecting to flank, hip, or thigh. It might be provoked by pressure on the joints. Clinical hints for diagnosis of facet joint syndrome include relief by antiflexion, higher pain in the morning, low back pain in retroflexion, and positional change.
Haven't you already voted on this?
No. It's a little bit double because we have acute back pain already done. But I think actually he had many more statements, Mirza. I put them together because we are still with 7, which is a lot. So this was maybe 2 or 3. I don't remember very well. So he prepared a very meticulous presentation.
What do you mean by it may be accompanied by? What is it? Facet joint.
It's facet joint pain. Where is that?
Because our first sentence is like feeling discogenic. So we can't say it. We have to write down facet joint pain may be accompanied by. Second.
Ah. Good.
When projecting to flank instead of, I will suggest delete flank. Flank is here.
Why? Sometimes they have this in the flank. Is that right? Not right? Flank is here. Here. Oh, kidney region.
Projecting instead of projection.
Projecting. Yeah, you're right.
Or radiating.
Okay, radiating. Good. Let's vote.
Very good.
Everybody voted. Statement 6. Lumbar facet joint blocks are gold standard for diagnosis of facet joint syndrome.
A good statement that we've already voted on.
Yeah.
We mentioned it.
Okay, then we can vote. And the last one. There's no evidence for lumbar discography as well as interdiscal interventions in the diagnostic of the discogenic pain. Then there's no evidence. Huh? Missing evidence. There's missing. What is the difference between missing and no? No convincing evidence. Okay.
We can forget it. It's not a clinical.
Shall we just, no, but it's in diagnostics. His topic was diagnostic of disc herniation. I think it's a good statement that it plays no role in the diagnostic of symptomatic disc herniation. Many do this. I mean, in the small hospitals in Germany, they still do this. I think it's a good statement. Are you okay with this, Mirza?
Yes, I think.
Okay, let's vote on this. Statement 7. Everybody voted? Okay, then Francesco, you're next. Mirza, stay with us 30 minutes, then we're done.
Yes, thank you very much, and sorry for the delay one more time.
No problem, no problem.
And greetings on everyone. I'm sorry not to be there.
Sorry, can I have support? Can I support? Can you? Because I don't have. It's work? Type C. Yeah. So we solved the connection problem. It's work. Yeah, now it's working. Certo. You want to access to, you know,
Full screen. F5.
Sorry? Is it okay?
ड्राइवर पे इशू है प्रेजेंटेशन कॉपी करना है
Can copy your presentation?
yeah, but we have to transfer to PowerPoint because it's in, you know, it's not a power. We have
That
just
would
to,
be easy.
yeah.
कॉपी कर लेते हैं कॉपी कर
कर ले ये आप निकालें इसको इस पे लगाएं presentation में ट्रांसफर करनी पड़ेगी
It's part of. I'll do it. Yeah.
ये लगाइए वहाँ पे
As a
वो वहीं लगेगी आप उस पे लगेगी ना
PowerPoint.
उधर भी नहीं है वो टाइप सी लगेगी और उसमें कनेक्ट होगा
And I'll do also for the mine that is in the afternoon.
ये ईमेल करवा लेंगे सर
This one. The second is this.
okay don't close it just give me a minute one minute
साइड में राइट साइड में राइट ड्राइव देना ड्राइव आई इसमें
drive
Once you
अच्छा ड्राइव उड़ गई
stress, everybody will know it's
yes sure I want to take this to WFNS folder it's down
Yeah, yeah.
continue.
okay
Francesco, did you fix it?
yeah just 1 minute
1 minute.
30 seconds
Okay.
30 seconds.
okay, remove kare लगाएंगे ना
ये लगाया जी लैपटॉप ले आया हूँ
Done. Mirza, can you hear me?
Let me fix it. It's fixed.
Okay.
Good. So these guys were just having coffee, so ready to start. Sorry to keep you waiting, and good to see you as always.
Good morning to everybody. I will present the lumbar disc herniation radiological diagnosis performed by Toshihiro Takami. I don't know if he's online right now. And we assess, he performed a very important work, and we assess, and I had to shorten it a little bit for timing problem. We have seen before this slide, according the rate of disc bulging that is diagnosed by an MRI. So must be very important to define the clinical aspect to request an MRI, because otherwise there is a risk to have a misleading MRI findings. The main question is the diagnostic value and the accuracy of the radiological images for lumbar disc herniation. Were performed a PubMed research from 2011 to 22. The first, it was more than 3,300 papers, and finally were selected 19 papers. The first question is when perform radiological diagnosis. In this paper is a review article of 2017. The author assessed that the first line imaging is the X-ray, and the indication for timing that exam must be performed after 6 to 12 weeks in absence of neurological deficit. They assess also that X-ray is not the diagnostic tool to detect the disc herniation, but is useful to have information and to make a differential diagnosis. The same paper defined that the magnetic resonance is the gold standard exam in the suspect of disc lumbar herniation, and in case of the presence of neurological deficit, strength deficit, the exam may be preferred to perform in an earlier way before than 6 weeks. Another paper, this is a review article a little bit before, is 2007, and again in the presence of severe symptoms and failure of conservative treatment, the advice is to perform some radiological test between 6 to 8 weeks. So in conclusion, for the question of when perform radiological diagnosis, literature tells us that radiological diagnosis is suggested between 6 to 12 weeks without neurological deficit, while if there is a motor deficit, the radiological test must be performed earlier before until 6 weeks. This is a suggestion. After we will have all the statements, just we can modify in case. So the statement suggested is in case of symptoms consistent of a lumbar disc herniation, a radiological assessment is suggested between 6 to 12 weeks without a neurological deficit and persistent symptoms. While in presence of motor deficit, a radiological diagnosis is recommended to perform earlier, less than 6 weeks. But which modality? Again, reviewing the literature, the NAS recommendation assess this problem, and they state finally that MRI must be considered the most appropriate non-invasive test, and computer tomography or computer tomography myelography are an alternative test in those patients that cannot, where there is contraindication to perform MRI, or if MRI fail to show the disc herniation. Regarding the computer tomography, a systematic review of 2012 says that the sensitivity of the computer tomography is more than 77% with a specificity of 73%. But with a contemporary multi-detector computer tomography, this rate rises. So right now, the new computer tomography machines are able to have answer similar to the MRI. So we have to keep in mind also what kind of CT scanner we have in our hospital. The sensitivity of the MRI is 75%, while the specificity is 77%, always in this systematic review of 2012, sorry. One of the advantages of the MRI is to define exactly and to have a grading system of the disc herniation. Here in this clinical research, they report all the classification and with a good results and a good inter-observer agreement of grading. Another advantages that we have seen with MRI, we are able to define also if if the disc herniation is extraligamentous or subligamentous. So is considered gold standard for the property to analyze the soft tissue and the relationship of the disc with the surrounding tissue with a very good accuracy. Again, I think it is important, especially considering all the facilities, to compare the low versus high field magnetic resonance. In this research of 2015, the author showed that there is an excellent agreement between low and high field MRI with the regard of the grading of presence and severity of disc herniation. Obviously, the quality of the images and the definition of the relationship is a little bit different, but to respond to the answer, if there is a disc herniation and where is located, there is no statistical difference between low and high field MRI. In this systematic review of 2018, the authors found 14 studies, mainly before 1995, including almost 1,000 patients. They investigated computer tomography, myelography, and magnetic resonance. And finally, they found that there is no statistical difference between the accuracy of the exam of the MRI and the myelography with respect to the computer tomography. So for the diagnostic tool, we can consider all of these three exams. Regarding the discography and the CT myelography, there is some studies, this is oldest from 2011, and the disc degeneration grades on MRI have a good association with the discography grades. So if we have to reverse, if we don't have an MRI, we can grade the disc degeneration with the discography. Again, for the far lateral lumbar disc herniation, there is a good correlation between the MRI images and the disc CT exam. So if it's not available an MRI, we have to keep in mind that the CT scan can be useful. Similar results are in this paper. While in this clinical research of 2017, there is a good correlation, a better correlation between the pain scale with the computer tomography, myelography, respect to the MRI, so it's more sensitive and can better define the pathology of the general lumbar disc disease, respect to MRI. Again, similar exam that show an equity or a similitude between MRI and discography. For the extraforaminal or far lateral disc herniation, there is some studies, some clinical research from 2012 and more recent studies that show that the MRI can detect the swelling of the dorsal root ganglion and the indentation of the dorsal root ganglion. So is a good way to detect also for lateral disc herniation. In this paper, the author suggests to combine two-dimensional with three-dimensional exam in order to better visualize the disc herniation. Similar results in a more recent paper. So in conclusion of these topics, which modality of radiological diagnosis, we can say that the plain X-ray is the first line imaging for the radiological diagnosis of disc herniation. However, it's not directly useful for the diagnosis, but are important for the differential diagnosis. CT scan have a comparable diagnostic accuracy than MRI, but is inferring the anatomical judgment of soft tissue. The CT myelography is the imaging of choice to visualize a disc herniation in patients with contraindication for MRI. So, but we have to keep in mind that have higher risk respect to the MRI. The new multi-detector CT scan have best anatomical visualization, so actually have a diagnostic level very near or equal to MRI. So we have to keep in mind also this. While the MRI is the gold standard imaging for the radiological diagnosis of lumbar disc herniation. This is the statement we will see later on just for timing and to fix it. But what are the new radiological perspective and which role can be they have? Our more recent paper from 2017 to actual days and are mainly based on MRI. In the next studies, we will see how the T2 mapping of the posterior annulus may be useful as a biomarker for the development from the bulging or protrusion to the disc herniation, and are all qualitative parameter and imaging biomarkers. There is a good accordance between all this clinical research. Again, accelerated tissue mapping is a quantitative imaging biomarker and is useful again. The role of standing MRI, there is some very recent article. In this paper, the authors showed that the lumbar herniated disc increase in size in the axial plane during the standing position, while in these other studies, the compression MRI showed that there is a good correlation with the L4, L5 space and L5, S1 space, while for the higher space from L1 to L4, the difference is not statistical differences. So have a marginal role if we suspected disc herniation from L4 to below. There is some new technique of diffusion with MRI or tractography that is possible. There are different studies from 2011 that show this, and is useful to detect the alteration of the tractography and the function of the nerve root. And is suggested mainly as a quantitatively evaluation and for the follow-up of the patient after disc herniation. Again, here are some review articles that show that is feasible and is useful essentially for the follow-up. And the last part is regarding the automatic reading, our very recent paper, and there is different type of study in order to have an automatic with intelligence, artificial intelligence reading of the MRI to detect the disc herniation, and there is a good agreement, more than 96% in this study, but also in all the other studies. So automatic, the human observation and machine learning doesn't present a significant difference. So in the next future, probably we have to keep in mind to have also these tools. In conclusion, we just summarize that diffusion tensor imaging is a promising MRI sequence for evaluation of microstructure changes in the nerve root, and it may be beneficial in understanding the changes that occur after disc herniation compression as outcome tool. And automatic MRI reading probably will be in the next future a promising tool, and we will use. This is the suggested statement, but we will go directly or each by one for the voting. Statement 1, in case of symptoms consistent for lumbar disc herniation, a radiological assessment is suggested between 6 to 12 weeks without a neurological deficit and persistent symptoms. In presence of motor deficit, radiological diagnosis is recommended to be performed earlier, less than 6 weeks. Sorry? It doesn't work to change? Ah, okay. Ah, okay. What? Okay. So what do you suggest, Salman? Radiological investigation, yeah. Okay, investigation here. It's okay. Can we vote? Okay, save, and we will later on.
Let's read that less than 6 weeks.
Okay, directly. Yeah. Okay, so I remove this one. Yeah, is okay. So vote. The second statement. Magnetic resonance imaging is the most appropriate non-invasive test to confirm the presence of lumbar disc herniation. Any comments, or we can vote? It's okay. So let's vote. No, sorry, I skip one. Plain X-ray images are the first line imaging for the radiological diagnosis of lumbar disc herniation, and although are not directly useful in the diagnosing, they are important for differentiating it from other lumbar pathological disease.
So then I propose to delete the first part. They are not first line imaging. The first line imaging is MR.
MRI, okay.
We already mentioned that. They were considered. X-ray images can be considered only for differentiating other lumbar diseases, pathological diseases. Can be considered.
Yeah, yeah. In a okay. Yeah, can be considered for differential diagnosis of lumbar disc herniation. I can copy this. Yeah, yeah. I just and not to be. I'm not able to. In this way, it's fit.
Can only be considered as an adjunct. We can make it weaker. Can only.
Okay. Can only be considered an adjunct for different. Okay, in this form, I don't like. Okay, that's okay. Let's vote. Statement 4. In case an MRI is not possible to obtain, patient contraindication, facilities limitation, etc., computer tomography or computer tomography myelography are the most appropriate tests to confirm the presence of lumbar disc herniation. Yeah, we are also to consider the where the MRI is not available. But and the rest. Also because literature said that CT myelography are higher results than computer tomography if you don't have a multi-detector CT scan. Yeah. Yeah. Okay, and statement 5. Diffusion tensor imaging is a promising MRI sequence for evaluation of microstructural changes in the nerve root and may be useful as outcome tools. I don't know if we want to take some statement about new perspective or not. Oh.
So you're saying it's a promising MRI sequence. So
Yes,
we can use it or we can delete it.
We will leave it. Yeah. Okay. Let's vote. Okay. And the last one is automatic MRI reading, such as machine learning analysis, is a promising as a future diagnostic method. I don't know. Is it in the same way? It's a new perspective. There is a lot of recent literature about this, but I don't know if we went put on the recommendation. Okay. It's okay. Thank you very much, and thank you to Toshihiro. I don't know if he's online. Okay.
So wonderful. You saved it where? At the USB? Okay. This is Imad. Imad, where's Imad? He can send it to me. He's in trouble? Yeah, yeah. It will be a stressful day. He will think Monday is holiday. Yeah. Okay, so Botello said that he's, oh, what happened now? Why is it gone? That's not good. No, that's not good. Oof. Because I changed it a lot. Ay. Let's see. Why is it suddenly gone? Oh.
Did you save it?
I don't know. I mean, I have it, but oof. It was right there. You saw it closing? Did you see it? Oh, it was there. Okay, wait. I don't know which one. This is the problem. Where can I find it? I have two versions. Let me see what this is. No, this is not the one. I think I used the other one. But I don't think that I might not have. Let me see. There. Good. Good idea. Nikolai, you're very good. Thank you. But now let's see if it's the right one. Yeah, it's the right one. Okay. So the next topic is symptoms mimicking sciatic pain. And Botello did not want to participate because that's true. So Mirza actually did both presentations. Thank you so much. I did not expect you to do both until you wrote me yesterday. So he sent this, and it's on sacroiliac joint and piriformis syndrome. I completely deleted sacroiliac joint because we have done this already. So we have now 6 slides and then 4 or 5 statements. Okay. The only problem is that piriformis syndrome is something I really have no idea about, not really. Okay, so methodology, same literature review, 2012 to 2022. 40 papers were found. This is about sacroiliac joint and piriformis syndrome. Okay, and this is the sacroiliac joint and piriformis syndrome. And now we switched to the piriformis syndrome because I deleted the 6 or 7 slides from the sacroiliac joint. Good, so how to find the clinical diagnosis? It's an exclusion diagnosis. So if you don't know what the patient has and he has chronic pain in the buttock and hip area, then it's piriformis syndrome. So which points out that this is a very difficult situation. It's worsened by hip movements, pain, getting up from a sitting position, and the inability to sit for extended periods of time. So these patients don't want to work. Diagnostic, clinical, ultrasound, enlargement of piriformis and sciatic nerve on the symptomatic site, and differential diagnosis is sleep gluteal syndrome, proximal hamstring syndrome. I think they are even worse than, I don't know all these. Okay, so physical examination, stretching of the piriformis. There are different tests. I think the best one is the, where is it? Okay, it's not very clear which one is best. I think this was, I mixed it up with sacroiliac joint. Various physical examination tests. However, they're all not very specific. So how do you do the diagnostic for piriformis syndrome? It's a clinical diagnostic. And then if you use the ultrasound, you might see enlargement of the piriformis and the sciatic nerve on this symptomatic site. Actually, if you have very good neurologists, and our urologists, they do all these peripheral nerve compression syndromes with the ultrasound. It's actually quite possible to see the nerve and to make the diagnosis, at least to see that the nerve is enlarged and there's edema of the nerve. So I think ultrasound, if it's in very experienced hand, is a very good modality. And MRI is rarely of any value. And well, the differential diagnosis, I went to the steep glottal syndrome, Hansen syndrome, and some other impingement syndromes. So they're even, I think, more rare. So what are the criteria? Unilateral or bilateral buttock pain, and without pain throughout the course of the day, with coming and going pain. No lower back pain. I think this is the most important thing, that you have no back pain. You have a painless palpation of the L2 to S1 area. You have negative Lasix sign. And this is also very important because you can definitely rule out any nerve root involvement when you do the Lasix maneuvers and the, well, whatever, all these maneuvers, straight leg, raising and everything. So it's not only Lasix. Sitting position is triggering the pain. And well, I would not, well, the sciatic pain with fluctuating periods without pain throughout the course of the day, as you have seen there. And then buttock pain with the stretching maneuvers. Well, there's a contraction resisting maneuver. I don't even know this, and palpation. And sciatic pain reproduced by the extension of the clinical maneuvers with stretching and contraction. An absence of the perineal irradiation. Radiation, not irradiation. Radiation. Okay. So you assign these different points. And then if everything is positive, you get 12 points. I don't know actually, Mirza, say how many points you have for the you need for the diagnosis. But it's obviously, it's very difficult. 7? Ah, okay. Okay. 7 points are required for diagnosis. Good, thank you. Well, the treatment is conservative. the medical management is what usually you try to do non-opioids or NSAID, pain medication and physical therapy. I don't know exactly whether this is a specific routine, but I know that when in our routine, when we have a patient suspicious for piriformis syndrome, all the physiotherapists do something else. I don't know whether it's the same in your hospital and your experience. It's obviously very difficult. You know, some think about fascia and acupuncture and about different techniques. So injection, if you don't know, if you cannot proceed any further and it's not working, then you can do a local anesthesia injections, and then followed by steroid injection, so the same. And then sometimes if it's a muscle spasm, the reason for the symptom, that's at least what in my experience, we do the local injection first with the corticosteroids. If they work, the pain come back. So then you know the diagnosis because it helped. And you know that the patient might involve this problem, and then you can do the botulinum injections. I've never done botulinum myself. It's done by the neurologists in our department. Surgery, actually, we have not done surgery for unclear symptoms. We have done surgery, some surgery in the piriformis area, but all these nerves had either an injury or a tumor. And well, the surgery includes the resection of the piriformis muscle, so to decompress the nerve, and can be done obviously endoscopic. I have no experience with this. Well, statement 1, piriformis syndrome is a clinical diagnosis after exclusion of other pain syndromes. It asks patients with chronic, it includes, let's do it like this, it includes patients with chronic buttock and posterior hip pain without correlation in the neuroimaging. Can we vote on this? Clinical diagnosis after exclusion of other pain syndromes. Good. You vote now? You vote now. What? Lunch is cancelled? Okay. So vote now, please. Statement 2. For the diagnosis of piriformis syndrome, at least one of the piriformis stretching tests needs to be positive. We went through these 4 tests. Can you vote on this? I think it's a very easy statement. Statement 3, conservative therapy with medical therapy with pain medication. And physical therapy is the first line of therapy. The first line, well, first line therapy, I think we can leave it like this. First line treatment, yes. Very nice, very nice. What? Okay. Good. Statement 3, please vote. Conservative therapy, pain medication, and physical therapy. This is conservative. No, it's to differentiate from the injection techniques. Next part is injection. Well, if it helps, probably it will be given for a very long time. I think it's fine. Statement 4, now someone, obviously he knows my slides. Or he knows Mirza's slides, I don't know. Second line therapy, second line treatment. Is local lidocaine and botulinum injections. I don't know if we should leave it like this or should do lidocaine and corticosteroids first. It's up to you. We have not done botulinum in the, we have always done local anesthesia first. We can leave it like this? Okay, he's very hungry. Okay, statement. Oh, look at this. I'm also hungry. Look at this. Statement 5, sorry. Third line therapy is surgery. Decompression with and or without piriformis muscle resection. In selected refractory cases, which showed good but short-term effect of injections. I added this. Mirza had not this, but I would not do it if the injection and the numbing the nerve doesn't help. A decompression will not help. Are you okay with this, Mirza? Okay, third line, good, no problem. No problem, surgery. Oops. Is that good? No, they showed it's past because you will not do it again. The history has to be positive for a diagnostic nerve block. Then you can do the procedure. Good. So we're done with this session before lunch. We have 6 more presentations to go. And I think, how much do we need for lunch? Someone, is it ready? We go for lunch down. Is 20 minutes enough?
30, because the guys will need time to break.
Okay, well, that's a good reason. So then let's say 5 minutes to 3. 5 minutes to 3, we continue. Is that okay? Good. Mirza, we go for lunch now. We continue 5 minutes to 3 if you want to come back. Okay?
So thank you and welcome for my second talk. It's about the cauda equina syndrome, its surgical treatment and outcome. The cauda equina syndrome is, in fact, not really precise defined. It contains a lot of clinical symptoms like back pain, radiculopathy, usually bilateral, but it could also in random cases be monolateral. Progressive neurological deficits in the legs on a motor scale or also on sensory impaired perianal and genital sensation, impaired anal tone, impaired bladder function. This may result in incontinence or in retention, fecal incontinence, and also sexual dysfunction. But we have to see that these clinical symptoms have quite a low specificity and sensitivity when regard that we say that cauda equina syndrome is then ascribed that also a radiological confirmation of the symptoms via, for example, a mass lesion compressing the cauda equina has to be found. So there are some specific wording regarding the cauda equina syndrome. So the abbreviation cauda equina syndrome, okay, but cauda equina syndrome under suspect means that there is these clinical symptoms with bilateral motor and sensory deficits, but no bladder involvement. This is cauda equina syndrome under suspect. We have cauda equina syndrome incomplete, where we have some bladder dysfunctions, but there is still a remnant of control from the patient. We have cauda equina syndrome retention when the bladder is dysfunctional, meaning there is either incontinence or retention of the urine, and cauda equina syndrome complete even if fecal incontinence arises. This all has to be confirmed via MR myelography that there is any form of mass lesion compressing the cauda equina. So this is the definition used by Todd and Dickinson in 2016, and this is what I would adhere to during the talk. Key questions for the talk are now, what is the optimal treatment modality here, and what's the optimal time frame for that treatment? The methods, what we did is we accessed full manuscripts. We looked for publications between 2011 and 2022 and searched again PubMed, Google Scholar, and Scopus. So what is the optimal treatment modality? As I said, all these clinical symptoms or part of it may be present, and we have an MRI finding of a, let's say, disc prolapse compressing the cauda equina. And to make it quite short, from my perspective, there is no other treat option than for decompression surgery. And when looking for literature here, it is impossible to find anything else of decompression surgery because there are no randomized control studies with a control group using, for example, conservative treatment. As in most countries, this would result in lawsuit or something like that. So to make that first question quite short, there is in literature no real alternative for decompression surgery, and that would also be my conclusion for that question. The more interesting question is now, when should this decompression surgery occur? And during the last 10 years, there have been 4, I would say, higher quality trials evaluating this question. And these 4 can be split up in 2 different study design types. The first type, as it was used by Shikandaya in 2015 and Hayes in 2018, they had quite a selected collective, and they described their collective quite well between the onset of symptoms, the time to administration to hospital, and also then the time to surgery. They had an excellent description of each patient regarding the extent of the cauda equina syndrome. So is it incomplete? Is it already with retention? Things like that. And these 2 studies are, as I said, the first and the third one here in this table. Interestingly, they also concentrate mainly on the surgical effect and time point, not independence when exactly the surgery after admission happened, but when the surgery happened after the onset of symptoms, what is from my perspective, yes, I would say the most important thing to define. So when is the time between onset of symptoms and the time of surgery, and what is therefore relevant for our treatment decision. And what they could clearly show is that if the onset of symptoms is below, at least the first study, is below 24 hours, the recurrence rate, or the not recurrence, but recover rate, is much higher than if you have a delayed surgery attempt. This is especially relevant in patients who have incomplete cauda equina syndrome. With patients having already a retention syndrome, the time of surgery was, at least during the first 72 hours, not so relevant. There was no statistical difference, but for those patients who had an incomplete cauda syndrome, it was clear that a very early surgery after onset of symptoms, at best within the first 24 hours, had the best outcome results. Quite a similar approach was done by Heinz, and he nevertheless did not show an advantage after 24 hours, but the first 48 hours. And here you could also see that there is a clear advantage after surgery within the first 48 hours. Interestingly, no further improvement of neurological symptoms occurred after 6 months in the follow-up. So if there was, after 6 months, still some bladder dysfunction, it probably remained for the rest of the follow-up till 2 years. Another approach was done by the other two authors, Thakur in 2017 and Hogan in 2019. They did quite a huge retrospective analysis of the NIS database with over 4,000 on the one and over 20,000 patients on the other hand. And they did not look for the onset of symptoms to surgery, but they look for the time of administration to hospital to surgery. And they also clearly showed, especially Turkin, that if you do surgery within the first 24 hours, the chance for improved neurology is significantly higher than if you delayed surgery here. Hogan et al. Did with the same database, but on bigger data collective, the search for the same question, and he found that surgery on day 0 or day 1, so within the first 48 hours, is superior to any delayed surgery after 48 hours. So, conclusion: all studies showed an improvement due to or after decompression surgery compared to preoperative baseline regarding neurological symptoms. Some studies showed that a very early surgery below 24 hours is probably beneficial according to later surgery. But we have to see that these difference in time of 20, or these time marks given with 24 hours have to be differentiated between onset of symptoms on the one hand and those who say this of the administration to hospital. This is the big difference between these two study cohorts. So coming to a voting, question first: what is the optimal treatment modality in cauda equina syndrome with MRI confirmed cauda equina compression? Statement 1: there is no alternative to decompression surgery, I would say. Do you agree? So, sorry, say again, I just did not get you again. Okay, yeah, okay, we can just, oh, that's this again. So you mean that I should just delete the question here in front and let the statement then alone? Yeah, of course, we can delete the question here, you mean? Yeah, okay. Okay, so you think so, you're fine then? Or you come up and, you can't see, Can you? Okay, so statement 1, no alternative, or there is, yeah. Yes. To copy the question inside again, of course. So you mean the question which was here above? Oh. So then statement one is the optimal treatment modality for cauda equina syndrome with MRI confirmed cauda equina compression is decompression surgery. Okay, good. So the second statement, maybe we work together on it a little bit. All studies showed improvement after surgery or after decompression compared to preoperative baseline. Not really, yeah. That's true. So my point is we have to discuss if we would include in our consensus the below 24-hour mark or the well accepted, let's say 48-hour mark. The 4 studies I showed show some, well, probably some evidence that the below 24 hours would be recommendable. But shall we include that so as a hard statement or not? Okay. Mm-hmm. Okay. Okay. I don't do anything. My fingers are not the first one. All studies showed improvement after surgery compared to baseline. Okay. Also in respect that this first sentence does not really take care of our topic here. What's the optimal time frame in the question? If I do this, I mean, we can let it be as a statement in the beginning, but it's okay. Good. Okay. Yes, the literature we highlighted has some evidence for that.
We don't say 6 hours, 8 hours. Expect better outcome. Weeks surgery should be performed as soon as possible. We can expect better outcomes. There is experimental study.
The last sentence delete.
There are studies showing that it's done with it. I would prefer that it stays. I would prefer it to stay. You can go for it, you don't agree.
Even sometimes 1 hour is enough. Depends on the pressure that is exposing. It also depends on the perfusion pressure of the nerve. Similarly, as with the spinal cord. So sometimes even 1 hour is enough for complete correct. Depends on the pressure. So not respect this scale.
We can. Do we have another statement? Because we must also mention the severity of the symptoms. If it is more severe, we will expect less.
Well, we can do that, but the one study showed quite well. I just go back to it. That if there is already retention in the bladder, then it was, in at least that study, not really relevant when the time point of surgery was after admission to hospital. So 24, 20. Mm-hmm.
But from the beginning, there is a very anesthesia, so that the outcomes are worse.
That's probably true.
Let's leave it like this. Make a third statement. Just statement 3 with the same question. And then the consensus meeting recommends early response. No, that's not mean as early as possible. But we can. The patient comes like this, and then we have to respond. And then they postpone it until tomorrow 8 a.m. And I'm sure it's better. What do you mean as early as possible?
Yes, we add that the outcome depends on the pre-operative damage.
Statement 3.
Yeah.
Statement 3, the outcome highly depends on the preoperative degree. No, but this if you have a patient with a complete bladder dysfunction, you will not be cured. Even after 1 hour. They recover, but they take time. They recover.
Maybe I'll show you how I.
Yeah. I'm going. Okay.
Okay, now we switch back to Ono. This is no, I have to remember everybody. Okay, so we switch back to the first block. Now it is the role of conservative therapy. I think that's very good presentation.
Yes, I will make it shorter. So my topic is lumbar disc herniation, role of conservative treatment. The questions are, which conservative treatments are effective? Is it treatment or just tapering of pain until prolapse is resolved? Is there an evidence that this herniation can be reduced by physical therapy? So I have searched the literature and I found 336 results. So the first question was, which conservative treatments are effective? So according to literature, it says that 85% of this disease can be treated by non-operative treatments. So these are the options: exercise, application of fat, cryotherapy, ultrasound laser, and TENS. This is a paper published in 2015. It says that physical therapy studies for acute low back pain and sciatica are heterogeneous because the intervention methods are variable. It's difficult to assess one method of physical treatment which would seem definitely to be superior to another. This study has separated the patients in 3 groups: health group, ultrasound group, and lumbar exercises group. And they say that all of these treatments have worked, and health and ultrasound had longer effects on same parameters. So another part that we have to discuss is bed rest. Some paper says that 1 or 2 weeks bed rest will be recommended because the pressure in the intervertebral disc is very high while the patient is sitting, and it's very low while the patient is lying. And having a bed rest removes the tension on the surrounding soft tissues. It improves local blood circulations, and it decreases the inflammation there. So another paper says that there is no difference if you compare 2 days and 7 days of bed rest. Pharmacotherapy, this study have compared non-steroids, opioids, and epidural steroids, and they found that there were no difference between them. Another study that I compared diclofenac, ibuprofen, and meloxicam, they said that meloxicam and diclofenac were equivalent, and meloxicam was much tolerated. In this paper, it says that non-steroids are effective at the acute stage of the lumbar disc herniations. Epidural steroid injection, there are lots of papers that Christoph has told us in the morning, sorry. This was a prospective multicenter study. The study design was like that. They have some epidural steroid injections, and the other group did not have an epidural steroid injection. And these were the results. In the surgery group, less of them has, in the epidural steroid injection group, less of them choose surgery. It was 19%. And in the non-epidural steroid injection group, 56 of them choose surgery. So in the conclusion part, the paper says that Epidural steroids are not better than surgery for lumbar disc herniations. So another paper said that epidural steroid injections are working, but no more than 2 weeks. My other question was, is it a relay treatment or just tapering of pain until prolapse is resolved? This is a comparative study. They have a control group and they have a percutaneous disc decompression group. At the conclusion part, it says that percutaneous disc compression had a better self-reported outcomes, and conservative treatment fails after 3 months. Another surgery study that have compared the plasma disc decompression and also the conservative physiotherapy, and they've seen that surgical treatment provided best relief. So is there any evidence that disc herniation can be reduced by physical therapy? I've searched the spontaneous resorption of the herniations. The incidence is 60 to 90%. Another paper that says that you may have 66% spontaneous resorption of disc herniations. These are the comparative studies. This is a good study. They have compared 400 cases, and they've seen that they have measured the rate of the resorption of the disc. They have calculated the spinal canal and the distance that involves the spinal canal here. There is a term bullseye sign. It means there is an enhancement around the disc herniation, and it means there is a new blood vessels there, and in the future it has more chance to have a resorption there because the new vessels are promoting the apoptosis here. So another study says that bullseye sign is important. Another comparative study with conservative treatment and surgical treatment. They say that lumbar discectomy is more effective than conservative treatment. This is a study that we have seen in Erica's presentation, Return to Sport. And they say that there were no significant difference between non-surgical and surgical groups. So my recommendations, the first one, will we recommend bed rest or not? Yes, Joachim. The literature says we may recommend. The other one says that you don't need it. There is no difference between 2 days rest and 7-day rest.
I was discussing with Onur about previously for acute low back pain, we recommend better. But this is disc herniation pain, and this is pain with
Sciatica.
radical pain.
Yeah.
So this can be different than the other one. So please do not confuse them.
One paper say.
Yeah, most patients will not be there. Right. I would not do it. Will you not sick leave? Sick leave doesn't mean anything. They cannot be active. But bed rest means that. But this bed rest is not a complete bed rest. I remember 30 years before I had this challenge. And my boss said that you must stay for 20 days. You don't move. You just go to the toilet.
Literature says you may recommend it, but the other paper says that there is no difference when they compare 2 days bed rest and 7 days. They are the same. So there is no evidence in the literature.
Rest is good. I like rest.
Rest.
I would rather say bed rest. Not rest. Yes. Because sitting and that's not rest. Inactivity. Inactivity. So they don't do much. It's okay. It's house they watch TV. It's rest. That's simple. That's standard. Yeah, that disagrees in all the areas. Told you.
Do I have at bed or not? So bed rest, yes or not? Okay. So recommendation 2, non-steroids are effective on improving acute low back pain and sciatica caused by lumbar disc herniations. The literature says that it's an effective method. And early in the morning, we tell that paracetamols were the first choice. If you look at the literature for lumbar disc herniations, they recommend non-steroids first.
That's what we recommend this morning.
Yeah.
That's exactly what we recommend. Yeah.
So is conservative treatment a real solution or just tapering of pain until prolapse is resolved? 60 or 90% of them resolves in time. The patients younger than 40 and the patients who has bullseye sign have the chance, have more chance for the resorption. Is it necessary or not? So I remove this one.
But without a resorption, patient may still be without symptoms. Well, that it's smaller. You might not see it on the MRI. Otherwise, you cannot explain why you should have without symptoms. The same level of pressure. I see many patients with good dreams. Yeah. Without it. No, I don't agree that there is it's completely wrong. Pressure must be less, otherwise they have symptoms. Either the root is dead or it's not compressed, otherwise they have symptoms. It's not compressed. Right. So, but then we know that 90% of conservative therapy, up to 90% is success. Studies have found
60% and some.
Then we have to do a different question. Then we have to show that radiologically we have 2/3 resorption. Not the clinical. We can measure the neurological. Yes. Yeah. I agree. Yeah. No problem.
So what do you write now?
Neurological. Then it's okay. That's what that is. That's nice. Nice. I would say it's one resolution. The first one is the first one. There must be no upstroke on patients. Statement 4.
Yes.
Conservative treatment is the treatment of choice for patients.
Conservative treatment is a. Yeah, what do I have to write?
Treatment of choice. It's the instead of
We will correct. What? We will correct the grammatic later, Salma. Is the okay. So the fifth, there is no high quality study to recommend physical therapy in lumbar disc herniations like exercise, application of heat, cryotherapy, ultrasound laser, and TENS. There are lots of studies, but the quality is low. So you cannot say this treatment is better than the other one.
Somebody will think that the surgeons has doing such recommendations. Maybe we can make a bigger thing. There is no high quality study.
Rare.
That physical therapy in lumbar disc herniation is beneficial. Instead of saying recommend, I think this is recommend. I think it's stronger. You're saying now it's not beneficial. Before we have said we do not recommend. Yeah, but with this sentence we are saying we don't recommend physical therapy. We don't say, oh, yeah. It's not supported. Still can do it. Or study to support physical therapy. Yeah. Okay, that's a nice idea. To support. Okay.
Okay.
Okay. Save it. Save it. Save it up there.
Yeah, I saved it. No, I use a shortcut here. It's fine.
Is it safe?
Yes.
Are you sure?
Yes.
Okay, good. So, hold. Okay. Thank you very much.
You're welcome.
It was a good job. So, who's next? The role of injection techniques. That was the low back pain. So let's see what it is like in the distance.
Is the PowerPoint?
So subject is not online.
So I'm not scared of one day where there is no flashlight.
Okay.
I thought all these countries have very good flashlight. Germany.
We have very good Wi-Fi. It's just
Germany.
in the forest.
Yeah. Okay.
Perfect.
Okay. Okay, ladies and gentlemen, I would like to present the role of injection technique in the treatment of lumbar disc herniation. Its presentation was prepared by Dr. Sandeep Ayasha. So the main question, we already discussed it for the back pain and for the lumbar disc herniation. It's estimated that 80% of people with experience at least one episode of low back pain. It's well understandable, but mostly the pain which provided by compression of root is disappeared without any treatment. The question was the mechanism of pain in case of herniation compressed the disc. So the pathological conditions is also well known because of avascularity of the disc and so-called dynamic mechanism of compression of the disc of the root. The final compression by the disc herniation is provided by several mechanisms of pain. It's inflammation, neural compression and dysfunction, vascular compromise, and biochemical influences. So percutaneous intervention for lumbar disc, which was discussed in this presentation, could be done by several ways. It's epidural injections, interlaminar, transforaminal, and via caudal epidural injections. The next variant, it's percutaneous epidural neurolysis, so-called adhesiolysis, and percutaneously also could be performed injections by ozone, steroids, saline, the ferments, and tocilizumab. What's the basis of epidural intervention in spinal pain? So corticosteroids, as well known, reduce inflammation, inhibit all synthesis and realization of pro-inflammatory substances, reverse local anesthetic effects, stabilize the membrane, inhibit neural peptides, and blockade cytokines. Local anesthetics introduced epidurally provide anti-inflammatory action, alteration of pathophysiological mechanisms, and percutaneous neurolysis performing as and named as adhesiolysis is can be done to reduce scar tissue epidurally from 30 to 50% and provide the decrease in the epidural fibrosis in case of compression of neural structure and vascular. So the procedure in injection of anti-adhesiolysis ferments performed usually during reinforced catheter with mechanical adhesiolysis and with injection, and you can introduce glucocorticoids, high pressure saline, and hyaluronidase. So the intradiscal therapy, which could be provided by delivering of drug directly in the disc, and also anti-inflammatory solutions and drugs, and intradiscal injection of through the different devices could combat biomechanical adverse factors. So the functional therapy also can be performed with facet joint innervations. Due to high innervation on facet joints, the introducing of different glucocorticoids or analgesic drugs can reduce the pain and work as anti-inflammatory agents. So many facets, joints, diagnostic and interventions rely on pain patterns and relief by blocking medial branch nervous signals. Here's the well-known article, intralaminar epidural steroid injections, which conclude the statistics of introduction this different kind of analgesics. So the conclusion was that statistically significant short-term improvement in pain in patients with lumbar disc herniation and stenosis, and it could be lack effectiveness against axial back pain. Another article, lumbar transfemoral steroid injections, conclude that substantial proportion of patients with lumbar radicular pain caused by contained disc herniations, lumbar transfemoral injections, or corticosteroids is effective in reducing pain, restoring function, reducing the need for other health care, and avoiding surgery. So it's the statement which suggested by Sandeep as a result of this presentation. So the meta-analysis which was included, it's informed regarding variance of administration epidurally injections and to lumbar disc herniation. It's first level of evidence, and could be used with combination corticosteroids and local anesthetic alone, and also a level 2 evidence is as injection to cauda equina. The evidence guidelines, epidural intervention in the management of chronic spinal pain. This Society of Interventional Pain Specialists concluded that evidence lumbar disc herniations, it's a procedure which performed with high quality fluoroscopic guidelines, with or without steroids, and level 1 evidence for cauda epidural injections intralaminar or epidurally. So it could be a strong recommendation for long-term effectiveness. Lumbar disc herniation in case of treatment with percutaneous adhesiolysis, evidence in managing disc herniation based on the high quality placebo control is level 2 evidence. Moderate to strong recommendation for long-term improvement in patients non-responders for conservative management and fluoroscopically guided epidural injections. Axial discogenic pain without facet joint pain or sacroiliac joint pain in the lumbar and cervical spine with fluoroscopically guided. It's level 2 evidence that caudal, lumbar, and cervical intralaminar epidural injections based on relevant high quality in each category. Moderate to strong recommendation for long-term improvement with or without steroids. Diagnostic phase may receive 2 procedures at intervals of no sooner than 2 weeks, preferably 4 to 6 weeks based on the type and dosage of steroid used. In therapeutic phase, after the diagnostic phase is completed, the suggested frequency of interventional techniques should be 2.5 to 3 months, no longer between each injections. Epidural injection as a statement should be repeated only as necessary according to medical necessity criteria, and it's suggested that these be limited to a maximum of 4 times per year. One paper which provide the quality and type of medicine could be introduced intervertebrally to the disc, and as a result of investigation in radical therapy, intradiscal glucocorticosteroids, short-term relief with glucocorticosteroids, or no sustained moderate positive effects of tocilizumab intradiscal therapy at short term, and a similar trend for etanercept in case of collected 2 studies. There also a paper which conclude the results condylase injection intradiscally. So the conclusion on the 84 patient, that's intervertebral disc injection decreased significantly at 4 weeks after injection compared with that before administration. Progression of intervertebral disc degeneration could be found in 50% of the patients, and disc administration improved pain and quality of life over the time. This papaya produced ferments, but it's not presented in Europe and Russia. That's why condolias. So as conclusion, intradiscal therapy has limited evidence suggests that intradiscal steroids are associated with the reduction of low back pain intensity as short-term. No clear effects for other therapies and positive effects of steroids and non-sustaining. So the recommended number of procedures limited to 2 interventions per year with 3-day protocol and 4 interventions per year with 1-day protocol. The best modality to diagnose facet joint pathology recommended as MRI, physical examination, diagnostic injection, and facet joint intervention. The level of evidence 1 and 2 with moderate to strong strength of recommendation for lumbar diagnostic facet joint nerve blocks. The level of evidence 2 is selecting patient for facet joint nerve blocks at least 3 months after beginning and failure to conservative management, strong strength of recommendation for physical examination and clinical assessment. The level of evidence is 4, based on symptoms and signs if diagnosis of facet joint pain with weak strengths of recommendation. Facet joint intervention therapeutical effect, the level of evidence 2 with moderate strength of recommendation for lumbar radiofrequency ablation. The level of evidence 2 with moderate strength of recommendation. The level of evidence 4 with weak strength of recommendation for lumbar facet joint intra-articular injections. Complications, adverse effect after associated with transforamular and intralaminar epidural steroid injections is concluded, is summarized in the article. They found that vasovagal reaction in 1.2% of patients. Dural punctures was found in 0.06%. No major adverse events of neurological injury, hemorrhage, or infections were seen. And increase in pain was seen in 2% of transforamular epidural injections and 1 and 2% in intralaminar epidural injections. So the final new article published in March this year, lumbar spinal steroid injection and infection risk after spinal surgery review and meta-analysis. Risk of all the spinal injections, intralaminar injections, was slightly higher in the spinal surgery was performed during 30 days after injections. The risk was higher for lumbar fusion cases, but not decompression only procedures. And last publications, use of transforamular epidural injections as the initial invasive treatment is similarly effective to surgical microdiscectomy and reducing pain and disability from sciatica with symptoms duration between 6 weeks to 11 months. Recommended treating physicians strongly consider the usage of transforamular epidural injections as stepwise invasive treatment for sciatica without neurological deficit up to 20 months duration. Surgery is still likely to be required for considerable number of patients for whom transforamular epidural injection might not be effective. So yeah, that's all. Yeah, that's the main problem because the questions inside the presentation. Yeah, yeah. No, it's converted to PowerPoint. So now it's could be seen. A moment. This is the first statement. In substantial proportion of patients with lumbar radicular pain caused by contained disc herniation, lumbar transforaminal injections of corticosteroids is effective in reducing pain, restoring function, reducing the need for other health care and avoiding surgery.
So we work on this. Yeah, you can a bit shorter. Because overall, I think it's okay. Yeah, because you cannot write it as a potential portion of patient. No, I will shorten it, but I will do it now. You have to give it to the because I have only I gotta do it. Yeah. Okay, so we vote. Let's consider it. Statement 1. Good. Go to the next. Next one. Oh, that's nice. That's a nice question. What is it? See. Oh, this is a lot. 38 slides. Where is it?
That's right.
Where's the statement? Yeah, no, I made another.
There's some conclusion.
Shall we go on this, on the frequency? Oh, wait. Oh. Shall we vote on this? Frequency of interventions. The number of procedures is preferably limited to 2 interventions per year.
Yeah.
With a 3-day protocol or 4 interventions per year with a 1-day protocol.
Yeah.
Shall we vote on this? Yeah. Okay, let's vote. That's recommendation 2. And then let's see. There was one more. Okay.
Diagnostic.
I think Pheasant we already have. I think this is not good if we do this. We have done that. Yeah, we skipped that. Complication we also have done an epidural injection. Okay, let's do that maybe as statement 3.
The overall risk of spinal injection was slightly higher in the spinal surgery was performed with 30 days after lumbar spine epidural injections. The risk was higher for lumbar fusion cases, but not for the compression only procedure.
Difficult. Shall we do this or we just skip this? I think skip it. Let's skip that. Go further. It's no problem if we only have 2. I think it's fine.
Well, this is the last 3 like statements. The use of transforaminal epidural surgical injection as the initial invasive treatment is similarly effective to surgical microdiscectomy, which is quite controversial, at reducing pain and disability from sciatica with symptoms duration between 6 weeks and 12 months.
Shall we say something about the difference between transforaminal injection and caudal block?
There is no comparison. I mean, no comparison in based on literature.
You have shown one. There was one. Let's see. Let's ignore that because it's fine, but it's only one study. Well, if you have radiculopathy, you do radicular injection. Well, the only question is if we do this, I mean, this is obviously a very strong recommendation, which I think is not true. So shall we vote on this or not? I cannot pretend, I mean, all our radicular blocks, they work, but not for 6 to 12 weeks. If they have severe compression,
They work maybe for.
They're about 6 weeks to 12 months.
Yeah, it's important. It's not with us.
Yes.
They come back, if they're very good, but they come back within 2 weeks. Then it's the same.
See, there is rare cases. That's probably what they need. Yes, you're right. The majority.
But here they say that this is the first line treatment. It's highly suggested that it's the same result as with microdiscectomy. I think.
Yeah.
I prefer not to vote on this because I have to listen to it.
You get this.
You show the vote on it? Then let's make it minded like this. Transfemoral injection therapy represents an alternative to microdiscectomy and predictable root compression.
Yeah.
Without
Can
deficit.
Let's say can be an alternative.
Okay, let's do that. That's the third.
Yeah.
We have all included that.
So maybe we can like somewhere on.
I do it right away.
Which number is that?
Number 3. The third we skipped because the third, I think someone didn't like. I write it. I just leave it here because I don't have the PowerPoint.
Last one, epidural steroid injection, maybe an alternative to microdiscectomy.
Exactly. Okay. Good.
But we can't get something like that. Certain patients.
Yeah. Similarly, I would say similarly affected in the acute phase of treatment, patient without severe deficit. Okay. Thank you, Artem. So who's next? Francesco, I think you're next, right? Oh.
So the results.
Yeah.
What's happening? Where it is, my presentation. Where is it? I don't know. I put some before. What?
The presentation is missing.
Where is?
Some surgery. You cannot stop now.
Was on the USB.
Where's Francesco?
Where is my presentation? I give you before on the USB key.
You're sleeping, Iman. You should give him the presentation. You don't put that voting. Voting is in 1 hour.
You told him to get the vote.
No. I told him to get the presentation. Go ahead. Sorry for the misunderstanding, Francesco. It was not. I did not want to.
Francesco, we like you standing there. That's why you found me.
Yeah.
This was?
Yes, this one. After you can send the email.
Yeah.
Okay. So, role of surgery in lumbar disc herniation. This is the main question that I analyzed and with the review of the literature. Just to remember, the aim of the surgery in lumbar disc herniation is to relieve pain and or symptoms of nerve compression and damage instead of curative effect of disc degeneration and reserving disc herniation. I think this must be important to keep in mind. Is still important or not? This is the review of the literature from 2,600 papers. We analyzed 283 papers. Regarding surgery, there is really a lot of paper and review. In particular, till 2021, there is 13 guidelines of recommendation. One of the most important that everybody knows are the one of the NAS published in 2012, where there is 3 grade B recommendation about the role of the surgery that is more effective to relieve symptoms in a short time. That surgical intervention prior to 6 months is suggested in patients with symptomatic lumbar disc herniation. And the other grade B recommendation is when surgery is indicated, there is no difference between sequestrectomy or aggressive discectomy. All the other recommendations, there is not enough literature analysis to make a recommendation, and there is insufficient evidence for all the other topics. In a successive guideline article from 2014, the results are similar to those proposed by NASA recommendation. Just to go to the more recent in 2021, and finally, they stated that the discectomy, when conservative treatment fails, is effective also when there is a neurological deficit. But the main topic that I analyze, when, why, and indication and timing in particular. We have seen before that the rate of the success of the spontaneous regression is up to 96% for disc sequestration, 70% for disc extrusion, 41% for disc protrusion, and only 13% for disc bulging. We have to keep in mind that surgery have a partial role in the natural history of the disc herniation. Similar results we have seen before this data about the 2/3 of the patients that saw without surgery. In this paper from 2015, the role of surgery is not so more relevant respect to the conservative treatment, also if there is a better result in short term, while in the long term results are quite similar, surgical, not surgical. In this other paper, the role of surgery, especially if there is a sensorial deficit, motor deficit, or the cauda-equina syndrome, are essential. So in this limited kind of indication, and again, similar results in this paper. Regarding the timing and the presence of a neurological deficit, in this review article, finally, the author identified that there is a 6.4% of difference between the outcome of patients who undergone surgery with neurological deficit and who were not treated by surgery. So they point the question about the role of the surgical treatment for these 6% of the patients. Different indication in this other paper, where finally the preoperative muscle strength and passive duration were statistically significant predictor of quadruple improvement, and surgical treatment is indicated before 6 weeks. So they are pro-surgery and with their timing well precise. This paper is not so clear. They put the attention that the indication for surgery is for symptoms lasting at least 6 months. That is a very long period. And the results finally are not so satisfying. I skip completely the timing of cauda-equina because we have just analyzed and voted, so we can go, but the results are the article the same, 24 to 48 hours. And the conclusion regarding when and why conservative treatment may be a role, we have seen that is the first choice of treatment if there is no neurological deficit. Surgical intervention is suggested prior to 6 months in symptomatic disc herniation with a radiculopathy, a sensor or motor deficit, where symptoms are severe or and conservative treatment failed, while early surgery, less than 6 weeks, is suggested in case of severe motor deficit because it is associated with better outcome. This is the statement suggested. I propose to skip statement 3, but we will see later because it's about the timing of cauda equina. What type of surgery is the second topic I try to analyze with all the literature. There is several types of surgery proposed and described in literature. In this review article of 2017, they compare 29 randomized controlled trial, and finally they found that percutaneous endoscopic lumbar discectomy have the better results instead of all the other technique. Similar results in this review article of 2018, where tubular and percutaneous endoscopic procedure are better than all the other technique analyzed. Again, in this review article, the authors concluded that surgery have a role to have a better outcome and a shorter recovery, and while for respect to all the other type of surgery, the so-called percutaneous discectomy, like laser therapy, thermal ablation, and nucleoplasty, have the worst results respect to all the other procedure. Again, an article is very recent, a review article where percutaneous endoscopic discectomy have better results in the short term and in medium term. And just to say that unilateral approach is effective also for bilateral symptoms relief. Again, there is different type of clinical article. This is very old. We have to keep in mind, especially for the endoscopic group, that the first studies compare the literature before 2011. So we have to keep in mind about this. And again, transforaminal endoscopic spinal surgery is safe, is considered an available technique, and is effective like open or microscopic discectomy. There is no superior. This is the review article that I said that the review is based on an article between 2000 and 2010. So I have to keep in mind that right now these review articles are oldest because the more recent literature are a little bit different. So I skip the review article before 2018. While right now we see that with endoscopic article, we have better results, especially in the short term, in terms of blood loss, drug administration, and pain relief control. Yeah, again, are almost the same. This is an ongoing studies, is a comparative studies, but is still not ended. So we will see, and this is the more recent from 2021-22, where the percutaneous tubular endoscopic discectomy presents better results than open microdiscectomy. So the author suggested is a study with more than 600 patients. And again, all the study proposed for endoscopic discectomy. We can skip someone because there is thousands of papers and a review about the different type of surgery. And in conclusion, right now it is impossible to rank one type of surgical treatment over the others at the present time. Generally, in meta-analysis, conservative treatment and percutaneous discectomy perform worse than all the other surgical procedures. Among the others, percutaneous endoscopic discectomy seems to have the best profile of safety and efficacy right now. Minimal invasive procedure for extraforaminal disc herniation appear to have similar safety profiles, but lower operative blood loss, operative times, and faster return to work. But there is insufficient data to make a very strong recommendation. And again, efficacy and safety outcomes do not support the use of tubular discectomy versus open conventional discectomy. This is the statement suggested, but we will discuss at the end. Regarding the type of surgery, independent by the technique, sequestrectomy or discectomy. Right now, like as in NASA guidelines and the guidelines that was published later on, there is no study in this review article that show that one technique is better than the other. So in conclusion, sequestrectomy and standard microdiscectomy of similar rates of control of pain, recurrence rate, and functional outcome and complication at short and medium terms. However, more evidence is needed to assess whenever sequestrectomy is associated with less postoperative analgesic consumption and the development of back pain, chronic back pain. And this is the statement that we will see later on. What is the role of surgical lumbar fusion in surgery? For lumbar disc herniation, we can see, as we can imagine, that there is no role, as the risk is higher and the results are not better. So in conclusion, in primary herniated disc patients with radicular symptoms do not benefit of lumbar spinal fusion. However, we have to think about symptoms. If there is a chronic low back pain, degenerative changes, biradicular symptoms, and radiological findings of instability of a lumbar fusion may be associated, but is not, in my opinion, a pure lumbar disc herniation, but is a more complex problem of the functional unit. This is the statement. What about the recurrence? This is another field that nobody right now have treated. In some papers is reported, like in this one, a rate of 12%. I think is a little bit higher than our in experience in Italy, but also in our. We have to think about this. And when there is a recurrent disc herniation, there is some study that propose just reoperation with the macrodiscectomy, and some authors that propose directly the fusion. However, there is no clear evidence of better results with fusion against only macrodiscectomy. Another study, and with a review and meta-analysis, and again the results are quite similar, comparing the risk of the spinal fusion regarding the pain relief of the disc herniation. In this study, they analyzed especially the pain of the back pain, and they suggested that the posterior posterior lumbar interbody fusion may improve symptoms of back pain. In conclusion, recurrent herniated disc patients with radicular and back pain symptoms may benefit with the lumbar spinal fusion, although complication rates, hospital stay, blood loss are higher. However, there is no studies that differentiates a first recurrence respect to the patients with more recurrence, and in my advice, this is very important. And there is no study where analyze in the recurrence patients group if there is instability and if there is some changes in the facet joint. So we have to keep in mind regarding this. So we can go for the statement. This is statement 1. Surgical intervention for lumbar disc herniation is suggested in case of failure of conservative treatment, severe motor and sensory deficit, progressive neurological impairment, and Cadaver syndrome. You agree? We can vote. We can do some changes. Oh, sorry. Early surgery, less than 6 weeks, is suggested in case of severe motor deficit and is associated with faster recovery and might increase paresis outcomes. This is the second statement. How can change And yeah, because
my lectures, I was telling instead of severe,
You need to change this? Edit one second.
okay, yeah. Sorry. In case of measure. In this way.
Now in the brackets we can write acute or less than 3 out of 5.
Okay. I don't know.
Acute or
After I will find the specific symbol because I don't know where it is. Is okay? Smaller, sorry. Smaller, okay. Is okay? We can vote. You don't like it? With faster recovery? Improve, yes. Improve. Improve. Oh, yeah. Yeah. Yeah, without, yes. Motor, prove motor outcome. You're right, motor outcomes. Right. Save. Statement 3. We skip it because we have just discussed and we have another statement in Cryotherapy syndrome. So I remove this one and this became 3. There is insufficient evidence to make a recommendation for or against the choice of a specific surgical procedure for lumbar disc herniation. Minimal invasive endoscopic procedures, however, present some advantages and actually is a valid surgical option. Yeah. Yeah, endoscopy. Tell me. Blood loss. Yes, sorry. Doesn't right? Why? Okay. Okay. Is a valid option. Okay. Yes, R. You see statement 4, not 44. Sequestrectomy and standard microdiscectomy or similar clinical results in terms of pain control and recurrence rate, functional outcome, and complication at short and medium term. Is okay? Do you want to change something? So, full stop here. Okay. Okay. Okay, so we can vote it. Sorry that I am saving just. Statement 5, not 6. Lumbar fusion is not recommended as a routine treatment following primary disc excision in patients with isolated herniated lumbar disc causing radiculopathy. Okay. Statement 6. Lumbar fusion may be considered in patients with herniated disc who have evidence of significant chronic axial pain, have severe degenerative changes, or have instability associated with radiculopathy caused by herniated lumbar disc. Ah, yeah. Or instability, yeah. Yeah. Together, okay. Copy. So statement 5, it became like this. Paste, yeah. It doesn't remove bold, it doesn't matter. So this is deleted and this became statement 6. So
all my talk is about
okay, delete. So 5, perfect. I save. Okay, it's saving and we'll send to you soon.
Yeah, please send it now. Now. So no break. Next month, now we don't have any break. We will try to be here at 7 at the bus. At 5, not at 7. Sorry. I don't want to try to just So next presentation is Mehmet on lumbar disc herniation prevention and treatment of recurrence. So we skip down bonus medullary syndrome. I give it later. The next. So forward for the whole thing. You need now to go to Mehmet's presentation.
Shortcut.
Yes, the prevention and treatment of recurrence has many sites. Sorry. These are my questions to answer. What is the definition of recurrence? We can start with this. In one paper, I saw that it is described that real recurrent herniations. So real or pseudo, this is something confusing. But we can tell that recurrent lumbar disc herniation is a new disc herniation at the same index level and site. However, many patients are having recurrences from the other side or from another level. These are not recurrences to me. What is the incidence? Actually, recurrence incidence and reoperation incidence are different things. Again, because of the definition. Reoperation rate is maybe as high as 19%. However, recurrence rates is about 3.8 to 7.4%. This is from a study of Aizawa et al. 2012. Can we predict recurrence before primary surgery? This is a good question. For instance, smoking has been found a risk factor for recurrence. But is it true for weightlifting after first surgery? Male patients, is it true that they are having more recurrences because of they do more heavy works? Obesity, in some studies, it's been said that obesity is a risk factor. In some others, it is not. This study from 2020 saying that associations among age and incidence of recurrent disc herniation, as well as time to recurrence, there is no influence of age. However, earlier reoperations in older patients, the recurrences are happening mostly in the first 1.5 years, not very late. But if you follow up the patients, because you'll see the late recurrences, then the recurrence rates are much. This is a meta-analysis with 17 studies. Smoking, disc protrusion, and diabetes have been found risk factors. Disc protrusion, this is a vague term, but actually they have, since many studies have classified disc herniations differently: protrusion, extrusion, and sequestration. So then extrusions and sequestrations, as we know, they can disappear easily, but subligamentous protrusions do not. So then we can expect more recurrences with subligamentous disc herniation or protrusions. What about modic changes? There are many studies that modic changes are very predictive of recurrence. So this is a good study from 2020 saying that recurrent disc herniation was more common in modic changes group. And again, this study has been done on a endoscopic, transformer endoscopic discectomy patients. So then they found if the disc material has got inside a hyaline cartilage, so they tend to recur. So hyaline cartilage group has more recurrences. Another study who has used Firman grading, the course of disease and modic changes, and the migration grade, similar to protrusion, extrusion, and free fragment classification. And they have found a close relationship with that. This study from 2015 found that male gander, large annular defect, and moderate disc herniation, again, like modic changes, has a good predictive value, as well as large segmental ROM, range of motion. So it means that if the level is moving more, or disc height is closing on the back, opening in the front on extension, and vice versa, those patients will have more recurrences. Again, what is the relationship? I could not understand well, but small L5 vertebral transverse process and low iliac crest height index. Another study again found that segmental ROM, but also lumbosacral transitional vertebra is a predictive, has a predictive value for recurrence. If you see a patient with transitional vertebra, you may expect more recurrences. What about can we prevent recurrences by surgical measures? This study says that minimally invasive discectomies have higher recurrence rates. And 16 trials, it's a meta-analysis from 2014 saying that more than 2,000 patients, minimally invasive discectomies have higher recurrence rates. But on the other hand, we must know that this study is from 2014 and have been done mostly many new studies. So then the surgeons are learning some minimally invasive surgeries. It may be because of the learning period. Another study, this study says that conclude that microdiscectomy has lower recurrence rates. This is from 2017. This is just my suspicion. I don't know for sure. This is another study saying that intervertebral disc lavage or irrigation of the disc level reduces the recurrences. This study says that there is no linear relationship between experience of surgeon and rate of reoperation. You can expect that more experienced surgeons will have less recurrences. Yes, they have found some number, 1.2-fold less recurrences if it is operated by a consultant instead of a registrar. But it is statistically not significant. What about the analysis of learning curve? They have found that ipsilateral recurrence are increasing by the time with learning curve. So then in the first 50 or 100 cases, you will have more recurrences. But after certain number of patients, it depends on the patient's, the surgeon's ability probably, it decreases significantly. And rate of recurrence after tubular microdiscectomy has been found 7.1%, which is still somewhat higher than microdiscectomy. And other surgical factors for about level of lumbar microdiscectomy or the amount of disc material you remove do not have any predictive value. What about annular closure devices? This is a new trend, actually. There are 1- and 2-year follow-up studies, especially from German and Austrian surgeons. This is so-called barricade, and there is one another. And this study says that annular closure device at the end of 1 year lowered the risk of symptomatic reherniation. In controls, it was 13.9%. Sorry, reoperation rate 12.9%. With the annular closure device, 6.7%. Then P value is significant. This another one collecting also annular tissue repair system, Annulex X Close. I don't know that, but actually there is one another. And they have found again a significant less recurrences with annular closure device. But I am thinking if there is some industry effect. What about the question, can recurrence be prevented by postoperative measures, such as activity restriction, stopping this smoking, losing the weight, and special exercises and muscle stretching? Unfortunately, I could not find good studies, even good retrospective reviews about this. I cannot tell anything about it. What is the best treatment of recurrent disc herniation? Just microdiscectomy or open surgery or fusion surgery? This is actually Francesco has shown some slides, but outcomes of recurrent disc herniation surgery. First of all, the outcomes are inferior to the primary surgery. We must tell this. This study from Fritzell, a Swedish National Spine Register study, Swiss spine study, is very reliable study with many patients, 13,000, with 11 years follow-up, and satisfied patients are 79% in the primary and 58% in recurrent disc herniation groups. This is a retrospective cohort. The conclusion is patients undergoing revision microdiscectomy are likely to experience worse postoperative outcomes, symptoms. What about fusion surgery? This is a one-center study with 73 patients saying that TLIF is a effective, reliable, and safe technique, but it is a level 3 study. What about this? This is a good study with systematic review, 37 studies. Satisfactory outcomes are similar, discectomy with fusion or discectomy without fusion. And then saying that back pain and Joint scores showed greater improvements in patients with discectomy and fusion. But complications of fusion surgery, 14.3%, is more than discectomy alone. And however, there is no recurrence after fusion surgery, as you may expect. But they conclude at the end, after too many studies, meta-analysis, there is no evidence to recommend the routine addition of fusion surgery in the management of recurrent lumbar disc herniation. I can skip this slide. It is a similar thing. There is an electronic survey from Ed Benzat's group looking at the trends in the for the surgical alternatives in orthopedic and neurological surgeons in the USA. There are many different approaches, and the surgeons in practice, more junior surgeons are choosing more revision microdiscectomies. More senior surgeons are choosing microdiscectomy only. However, juniors are selecting more fusion surgery. This is interesting. So then, if there are fusion, the siders of fusion, then they must be younger. The debate on most ideal technique for managing recurrent lumbar disc herniation, a short review 2017, fusion should not be undertaken in all recurrences, but should only be considered as an option for revision when spinal instability, deformity, or associated radiculopathy is present. And it has for sure, it has more cost than microdiscectomy, and conservative treatment is more cost effective. Then it follows with discectomy, and then more costly is the discectomy and fusion. So we can come to the conclusions. Recommendation 1 is the recurrent lumbar disc herniation is a new disc herniation at the same index level and site. This is a description. And recurrence incidence is between 3.8 to 7.4%. Reoperations after a disc surgery may be from contralateral disc herniation or another level herniation. Reoperation incidence is between 5.2 to 19%. Do you suggest any changes? But as I mentioned to you, real recurrence have been said that it is the definition of the same site. So then the recurrence may be considered as a complication of a disc herniation surgery. But if it is from the other side, you cannot consider it as a complication. If you wish, we can change. Okay, voting. Second, these are prediction of recurrences: smoking, younger age, male gender, obesity, diabetes, persistence of weightlifting after first surgery, modic changes, Firman grade, migration grade, large segmental ROM, presence of lumbosacral transitional vertebra may be factors to predict recurrence of disc herniation. Too many things I wrote here, but these are some. We can delete it if you wish, because instead of migration grade, where the migration is more important, we can delete. Sequester migration, delete all migration. Yeah, this is better probably. Okay, voting. Recommendation 3, minimally invasive discectomies, endoscopic, etc. may have higher recurrence rates. Do you agree with that? The level of lumbar microdiscectomy surgery and the amount of disc material removed have no correlation with rate of recurrence. There is a trend toward intervertebral disc lavage during reducing the rate of recurrence. Yeah, there is only one study, right? What do you think? Actually, I'm also doing myself, but it doesn't matter. Voting?
Yeah, the problem is that in most of the early studies, the persistent symptoms were more. Many studies are arguing that it's correct procedure, not taking the recurrence. Right now, at least in our season, we just have worked up the last 500. It's not true. Yeah, but they don't differentiate because they do post-separate lines. So this is I mean, based on the literature, probably it's not.
Yeah. There is no linear relationship between experience of surgeon and rate of reoperation. However, for endoscopic and tube-guided surgeries, more recurrent herniations can be observed during learning periods. Huh? But it says recurrences, not the remnant. Yeah. Let's vote it. If you are against, then you can say disagree.
I mean, we have that it's hysterectomy alone. We have evidence that extensive hysterectomy.
Yeah.
Why should if I decompress the root and I'm a junior one year of experience, decompress the root, and why should it be worse? Why should there be a higher recurrence?
Yeah. We already voted that in with Francesco's presentation. Francesco has also already did it.
Yeah, but then look at carefully in the papers. They never did MRI after surgery, and then they followed, and then they said new recurrence.
Yeah.
Based on the papers, it's right, but I think my experience is wrong. I'm sure it's wrong.
Yeah.
I have a problem that we put this in the recommendations. Because this gives another, in the training, this is another excuse not to let them do anything. Okay, delete.
This sentence, however,
Yeah. Otherwise, we should.
Yeah, actually, this may be an ethical issue because we teach always. So then, if the juniors are having recurrence,
There's no linear relation between experience of surgery and rate of reoperation. This is nice. That's so good.
recommendation 5. What? Rate of reoperation, we call it, not the primary surgery, not the outcomes of primary surgery. We just say reoperation rates are they increasing with the level of experience? No, it's not. Among patients with large annular defects following lumbar discectomy, additional implantation of annular repair devices may lower the risk of recurrence in 1 and 2 year follow-up. The long-term results are not well known. And I noticed that in their paper describing the technique, they during the surgery they measure the width and length of the annular defect and decide accordingly to place an annular closure device or not. So then this is unbelievable. How do you measure it? Is it? I could not understand that. I'm idiot. Remove all the sentence. Okay. And what is else? This is 5. There is no evidence to conclude that recurrence can be prevented by activity restriction, weight loss, smoking cessation, and muscle stretching exercises. And now the last 2. This is 6. No. Clinical outcomes of surgical therapy of recurrent disc hernia are inferior than initial surgery. Patient satisfaction after primary discectomy have been found 79%, after recurrent discectomy 58%. This is Swedish study. Recommendation 7, there is no good evidence to decide the best treatment option for recurrent disc herniation. Although back pain responds more to discectomy and fusion, the routine addition of fusion surgery for recurrent tumor disc herniation is not recommended. Fusion should only be considered as an option when spine instability, spine deformity, or associated radiculopathy is present. Although complications are less with microdiscectomy than open discectomy, the outcomes are similar. Okay. Probably we can delete that cost sentence. All the sentence? No, we must tell something about fusion.
There's no good evidence to decide the best treatment option for recurrent destination. Yeah, we can just stop there. We have already voted on when to do.
We did not vote for fusion before.
Yes, it is.
But for recurrent disc herniation. No. But not we omitted that.
But why should I mention fusion? I mean, it's that there's no evidence to decide the best treatment.
No, there is a place of fusion, but in case there is instability.
We do fusion if we have three recurrent.
You will have then fourth recurrence.
No, it's fusion not.
Or fifth recurrence. Huh? I'm deleting this. How do you say?
This one and the one before fusion.
Fusion.
In between, the one in between, the second one, the normal one. This, take this out.
Should only be considered. Yeah. Okay.
Okay. Good.
This is it. Shorter.
Excellent.
Good.
Okay. This was now 7.
Come on. I'm sending you.
Yeah. This I cannot remember. So every 4 or 5 years before I set it up. So what do you do when you have a young patient and they have within 1-2 weeks 2-3 recurrences? I have 3-4 patients every 5 years. I have one. What do you do then? Do you do fusion or you just keep on going? Well, recently we had an American young soldier. Well, recently it was 3-4 years ago. We had done 3 surgeries in 2 weeks because every time a giant disc forms. Take it out, everything looks fine.
You should make fusion. Then fusion. I've had.
When do you do fusion?
That I did 3 and
After second.
after second surgery. The third time you.
Okay. Good.
So let's put it there. I after Prevalence says I always do fusion. You just said it after seconds.
Oops. So now I do the conus medullaris syndrome. This is the talk Scott Robertson prepared. I will try to be very fast because we have now 5 o'clock. I wanted to leave now, so we are late, even late for late. Okay, So literature review for 10 years. These are the database used. Conus medullaris, so 779 references. And then definition. It affects approximately 14,000 patients in the United States. It's most susceptible to injury because of its proximity to the thoracolumbar junction. The conus medullaris lies on the clinical spectrum between, the syndrome lies in the clinical spectrum between classical spinal cord injury and cauda equina syndrome. And patients present with a mix of first and second motor neuron injury and various dysfunctions. And variations might be in level from T11 to L3, I think. Well, it's very wide. Usually it's L2, L1, L2, around L1. So what is the difference between cauda equina and conus medullaris syndrome? What causes conus medullaris syndromes? How to treat? And is conus medullaris syndrome an emergency surgical timing? I think good questions. So this is his table. I don't know where he got it from, but I think it makes sense. So conus, L1, L2, compression, injury to the cord, and cauda equina, L2 to sacrum, vertical level. I don't know actually what he means with this sacral cord. I don't know. Causes L1 fracture. I think the most frequent one is a fracture. Sometimes a very big disc prolapse. Sometimes you have some stenosis and you have a small disc prolapse. So it's not that infrequent. And then of course you have conus medullaris tumors. So epidemioma, in my opinion, it's the most frequent one. Vascular injury, okay. And tether cord, oh, okay, very rare. So then cauda equina syndrome, you see these fractures, but mostly we talked about degenerative like disc prolapses. The signs are a little bit different. Normal motor function, I think this is not true. EMG normal. I will not go into this. Don't forget about it. I think this is wrong. Sorry. You see here the swelling of the spinal cord. So we just recently did a conus syndrome in a patient. He was basically like a spinal ataxia. This patient could barely walk on a walker and had no weakness. You know, he was like a sensory ataxia. So etiology, disc herniation, or here pathological fracture, trauma, tumor, metastasis, abscess, hematoma, stenosis, vascular. How to treat? The MRI is a gold standard. I think it's important, the MRI, particularly if you have any vascular issues. The CAT scan is not as good. And also frequently you have just a very subtle finding in this area. So like I think MRI is really, you have to get an MRI if ever possible. And the treatment is surgical decompression via laminectomy with or without subsequent discectomy, bone removal, tumor resection, etc. Benefit of steroids, controversial, often dealing with both cord and nerve root injury. There's very little specific literature on conus medullaris syndrome. The recommendations basically refer from the cauda equina syndrome, which I think is, to some degree, you can do this, but you have to have in mind what is the recommendation for spinal cord injury as well. And so we have gone through this, the early surgery for the cauda equina syndrome. I will not do this again, but for the cervical and thoracic spinal cord injury, there are studies supporting early surgery in less than 24 hours. So we have to have this in mind that probably when we come from the cauda equina, we consider that additionally is a spinal cord injury. It's probably more likely that the surgery is more urgent than in the cauda equina. This is a nice study. There's a retrospective review of 95 patients with spinal cord injury. T4 to S5, and the patient was stratified to the level of injury and the neurological outcome. And 93 of the patients with cornus medullaris syndrome demonstrated improvement of at least one Asia grade, compared with only 22 patients with a more cranial level of injury. So overall prognosis is good. And this is, in this paper, there was no discussion on the potential reasons and what is whether operative or non-operative management. But there's always a discussion about nerve root escape. So they mean that there's a higher density of lower motor neurons, and this higher density causes, as a result, gives a higher number of motor neurons surviving this compression. This is what is called nerve root escape. Well, this is the idea why the cornus medullaris injury has a better prognosis than the spinal cord injury. So there's a higher density of neurons, and because of this higher density of neurons, more neurons will survive, even if like 90% are dead. When you have 3 times more, then you have still 3 times more than a spinal cord injury. Early intervention by surgical decompression in patients with cornus medullaris and cauda equina syndrome is associated with better prognosis. Well, this cornus medullaris syndrome is not supported by literature, when just supported by the cauda equina syndrome, and then, for example, by this paper with certification of the level. Surgery is recommended within 48 hours of initial presentation and less than 28 hours when possible. The longer the compression continues, the worse the permanent structural and functional impairment and the poorer prognosis. And presence of bladder dysfunction prior to surgery has been linked to poorer outcome. This is the same as the cauda equina syndrome, and also the same in spinal cord syndrome. So conclusion, management of acute cornus medullaris syndrome is still controversial. No class 1 randomized trials are performed or have been performed. Nevertheless, consensus has not been met regarding the optimal treatment strategy for those with neurological deficit. Although operative treatment is generally recommended, with regards to timing on operative management, there's no randomized study available. Just when we use the cauda equina syndrome data and the spinal cord compression data, then we should do surgery as early as possible. Yeah, this is this one. Generally recommended surgical decompression to be performed within the first 24 to 48 hours of initial presentation. And the role of steroids is controversial. There's no class 1 study available. So these are his proposed questions. And these are the references. And now we come to the statements. MRI is gold standard for diagnosis of cornus medullaris syndrome. I think this is easy. If you want to, we can make it more pronounced, because I think MRI is really, indispensable. We have to have MRI. Okay, it's different from lumbar disc, I think. We also have shown lumbar disc gold standard, but here you have to have it. Okay, vote please. Then statement 2, treatment of choice is surgical decompression with or without fusion. Well, I actually had in the beginning surgical decompression. These are statements I did. So, but because he pointed out fusion, and frequently there's a fracture or thoracolumbar instability with it, maybe we should do with or without fusion. Okay, you're done with voting? You're very fast now. It's not done yet, guys. Statement 3, since cornus medullaris syndrome is a spinal cord injury surgery, should be performed as soon as possible, as early as possible. This is not good. Let me check in. It's fine. Then let's do the others. Since cornus medullaris syndrome is a combination or something of spinal cord injury and cauda equina syndrome, surgery should be as soon as possible. It's not good. What do you want? Should be performed, yes. I think it's important to have this separate because there's actually no evidence, but I think it's very clear that it has to be done as early as possible. But there's no evidence at all because we can only say that patients with injury in this area, they do better than other spinal cord injuries. Are you not okay with it? Yeah, I'm happy to delete it. I just edited it because Scott did so much work on this. I think this is fine with me. Treatment of choice is surgical decompression. I mean, if there's fracture and instability, you have to add fusion or vertebral body replacement. Like that. Then statement 4, evidence for the benefit of steroids is lacking. Then you can do whatever you want. Who would do the dexamethasone? I think we would do.
I think we all would give it, but we know that.
We know it's not working, but since it's, we hope that we do something good for the patient. Okay, that's it. No more than that. No, we're done. We're done. This was the last talk. I have now prepared. Where is it? Oh. So I think the next step is now, where is Imad? Imad has to show us the results of the voting. And then I have next steps, that's just 10 minutes to discuss how do we proceed to the next meeting. Let's see the voting and then everybody can go. And then is the buses there? Can we leave at, let's say someone, can we leave at 5:30 latest?
So can we have buses for 5:30? It's fine. We leave at 5:30. So we're just going to see the votes and then accept the fact that we can have a group photograph. Okay, we might not have it up. Although we can have it there, and there's still
What happened? The cadavers are gone?
Cadavers are there, but now they're civil hospital guys with whom we had spoken to and had confirmed that we are going to share cadavers. They're saying that.
So we don't have cadavers tomorrow.
We don't have it into night session.
Okay, no problem.
Are we getting? Okay.
So don't worry. So Iman, don't get confused. Show us your results now. Don't listen to him for 5 more minutes.
Professor.
Okay. You have to go. Just speak. You can go to the results. Statement 1, back pain, epidemiology, and prevention. So we have to go back. This will take a lot of time. Let's not do this. You know what we can do? We can do for all participants. I will set up this thing. You give me this, and then I give you the question and answers. I put it together.
You don't need to do that. You get one of the lessons.
How do they do this?
With brain.
Yeah, but they need the questions.
Questions, obviously. Okay, you want to do it, fine. And you have your later.
Yeah, we do it during the flight to Bahrain.
Yeah, so you have
Okay, so thank you very much, all of you, for attending. Let's do one picture.
Good that we have bodies. Huh? Good we have bodies.
Yeah.
Otherwise, we could have. I would have sorted some case out somewhere.
Come, not so slow. Let's go. Come on. You're not so shy. There's no horse to ride. Come.
You all can come here.
कर दिया वो ईशान से बात कर रहा है ठीक
Yeah, we were done today. So
Tomorrow morning on time.
what time? No, I don't think so. 9 o'clock is not possible.
8:15 is to be here. 8:30 start sharp.
Now 8:15 in the bus.
No.
8 in the bus. Who was late this morning?
We are talking about this evening. This is for this evening. This evening, we must be there for 7:30.
7:30 leave or
No, this is, let's not